Okay. Good morning, everybody. Welcome to the Trust Board July meeting, meeting in public. We will be live streaming this meeting again, so welcome to people who are watching virtually. You're very welcome to join us. So if we could do apologies for absence, we've got one which is Steve McGowan, our Director of Workforce, and Helen Lambert, his deputy, is standing in for him today. So welcome back to the board, Helen. Thank you very much for joining us. If we move to item 2, which is the declarations of interest, you've got the paper. If there are any changes or anything new, please let Jenny know. And if there is anything that presents you with something where you need to declare an interest or a conflict of interest, please do, and remove yourself from that item. So if we can move to the minutes of the meeting held on the 24th of June. And then we'll go straight into the patient story after that. So are there any points of accuracy that you've not already let Jenny know? Any matters arising that are not on the actions list? No? Well, if we just complete the actions list and then we've completed that section. So anything on the actions list? Item 4.
Yeah, Sharon, just on page 2 of it. Just the update on the population health management and links into LICRA, which says it will be confirmed when the COVID-19 situation has ended. And I'm assuming that COVID-19 actually won't end. We're now into a different phase. I just wondered when that was going to come back onto the agenda.
Sharon, Chair, is it just me? But there's a bit of background on Francis's network. You're on mute, Sharon.
Sorry, Francis, we have got quite a lot of feedback on your network. I think it was you that was creating the noise. Do you want to try again?
Yeah, all I was saying was that can you hear me now?
Stuart, sorry, can I suggest that you dial off and dial back in again?
Okay.
Sorry, it's just that there's a bit of an echo. The other thing, Chair, we've got apparently some hands out working, Dean's, and Francis has said it wasn't. So what I'll do is if I keep an eye on the message box, I'll raise mine if they need to come in. Is that okay?
That's perfect. Thank you very much, Michelle. That'd be helpful.
Is that any better?
That's much better, Francis. We can hear you loud and clear now.
And I've also got hands icon button now for whatever reason. Yes,
well, result all round. So ask your question again, please, or your comment, Francis.
Okay, it was on outstanding actions 26/2/20, which was about the update on the population health management and links to LICRA, which had been delayed because of the COVID-19 situation and was parked until it ended. And I think we all know now that it's not going to actually end. It's just going to change its phases. So I just wondered when that was likely to come back up.
Okay, somebody want to answer that?
I'm happy to answer that. I'm looking at the action notes and I see we're planning to bring that in September, Francis.
Okay.
Okay, all right, Francis. Anything else on the actions list? No? Well, without further ado, then, I'd love to move into the patient story, item 5, and I'd love to welcome Alison and Dave to the board meeting. Thank you both very much for joining us this morning and giving us your time and the benefit of your experiences and views. Really welcome at the board. The board really values hearing from people such as yourselves, and it really makes a difference to us. John, would you like to introduce this?
Good morning, Chair. Yeah, thank you to Alison and Dave again. I suppose just what I would say here is that it's a really important topic that we're picking up, alcohol, particularly in light of what's been going on in lockdown. And I think the story we're going to hear this morning is going to resonate with some of that. And I suppose there probably isn't a family across the country which doesn't know somebody somewhere which hasn't been affected by alcohol. I see Alison nodding there. So particularly those of us there, I said, Alison, from an Irish background, have a particular problem with the drink or alcohol or gargle, whatever euphemism we want to apply for it. So I'll be fascinated to hear your story, and I suspect from a personal perspective, it'll resonate with me and hopefully with some of the people who are listening that it is a difficult situation, but it's not beyond hope. And I think that's what hopefully your story will bring to us this morning.
Thank you, John. Alison, would you like to start and then we'll hear from Dave, or would you like to do it in reverse?
I'm happy to go first, if that's all right. Can I say thank you, John? That was interesting. You saw me nodding. For years, I've heard the sort of expression, well, there's an alcoholic in every family. And the more I've got involved as the years have gone by, the more I believe it's true. Somewhere in, I'm not saying for everybody, but very, very generally, if you look back in the history of the family, it might be a grandparent or a distant uncle or aunt, but more people do recognise that it is, the extent of the problem. I'm happy to identify with the term alcoholic. I will explain that. I don't mind the label. I can cope with it personally, but I do understand other people. It's such a derogatory term. It has so much stigma attached to it that a lot of people prefer to say they have a problem with alcohol. Yeah, I have a problem with alcohol. It likes me too much, or I like it too much. The situation I got myself in, I became physically dependent on alcohol. Some people don't suffer the shakes as I did, but I hope you've all had your breakfast. But I would wake up in the morning, and at some stage, sometimes even before I got out of bed, I would be dry retching, and that would prompt the shake starting. And the only way I could solve it was reaching out and pouring myself, in my case, a stiff vodka. And after one or two, it would settle down and I'd be able to sort of function. Unfortunately, after one or two, you don't stop, and the whole day sort of spread through. Having said all that, I was a functional alcoholic. I mean, I did keep the job down, but as you can see behind me, I'm actually in my office. I work for my husband from home, which gave me all the opportunity to indulge in my drinking. I didn't physically go out to work. So really, when I look back, I can't pinpoint a moment in time when I thought, oh, I've got a problem. But I'm reckoning on something like 30 years. I actually moved into this bungalow it was in August 1988. And my then husband said to me, on the moving day, we'd moved in, and I went to get a bottle of wine, and it was middle of the afternoon. He said, oh, you're pushing it a bit, nicely. And I suddenly thought, oh, yes. But as I say, apart from that one instance, because it was moving day, I can't really talk about a moment in time. As I say, I worked from home for my second husband as time went on. And I did distract myself through periods of time. I got some part-time work just to supplement, because Carrie couldn't afford to pay me a huge income. But I took up a couple of part-time jobs, but eventually, I didn't actually get my sack, but I left before, I jumped before I was pushed, sort of thing. I even tried to undertake a degree at Lincoln University to try and keep myself sober. That lasted about 6 weeks, I think. And I was on various committees. So I did function as over those years. But the other major factor in that period of time was actually had to surrender my driving licence on 4 occasions. Now, 3 of those was when I was a passenger in a car, once with my husband and twice in a taxi, where I hadn't been feeling particularly well, so I opted not to drive, obviously, and I blacked out and ended up in Humber Infirmary. The 4th time I did actually have a drink driving offence and ended up in a field. So the fact that I actually surrendered my licence 4 times, the problem was I then had it in my head, I can't drive, so I might as well carry on drinking. Some people would have said, oh, you can take that opportunity to get yourself sorted out. And I must admit, my occasions in Hull Royal Infirmary were not, apart from the middle occasion, they didn't lead to me automatically going into treatment. I eventually found my way to my doctor, but I say, apart from that one instance, the doors weren't sort of spread open, and somebody didn't sit on the end of my bed and say, come on, Alison, there's some services out there. Now, this is going back to 2000, 2003 and 2007. So we are talking some time ago. But it is something that I know is very difficult, but it would have helped if something, even if they didn't sit on the end of my bed in Hull Royal, a phone call the next day or the day after perhaps would have helped. I'm not saying it would have done when you see my drinking history, but it was just my attitude really was, And I think it comes down to the basic fact that I didn't really want to, and I'll come on to that in a moment, but until you really click up here, and I don't know what it is that clicks up here, you're banging your head against a brick wall. Now, having said that, I did have periods of sobriety, and I have used the service. Back in 1997, I had a one-to-one session. I think it was actually under the DART heading in those days, and I remember people commenting how well I looked. 2006, 2007, I went to Baker Street, and that was a 6-week. Again, that was a group session, and achieved some sobriety after that. But unfortunately, by the end of the year, I was back in Hull Royal Infirmary with one of my fits. So what made me change? I mean, basically, I've run from identifying that I was having a problem, certainly in the late 80s, running through various occasions, various periods where I had the opportunity to take advantage of professional advice. But what happened in May 2015? Well, quite simply, I woke up one afternoon out of one of my sort of blackout sleeps, because my routine often was to make sure I had enough sort of drink for the morning, and then often I'd be blacking out by about lunchtime. When I said blacking out, I was asleep. I was deeply asleep. I wasn't actually dead to the world in that terms, but I was sort of, you know, quite heavily asleep. And I'd wake up about 4 o'clock in the afternoon. And this particular day, I just, something up here suddenly said to me, I've had enough. I'm sick of being sick. I didn't have any particular money problems. There was no great financial, the bank weren't chasing me. Certainly no legal issues or anything like that. And no particular health issues, which I find very amazing. It was just an overriding sense that I could not go on anymore. It's just one afternoon, nothing had prompted it. So I was ready to accept any help on offer. And I was fortunate enough that I had a very sympathetic doctor, he had to be. And he made an appointment for me to see a lady from East Riding Partnership. And actually, looking at my notes, I actually saw her within a couple of days, which was marvellous. And her reaction, having read all my notes, because bearing in mind, they probably have notes that thick on me, straight away she said, Alison, it really is time for you to consider inpatient detox. Now, that hadn't been suggested in the past. And I immediately burst into tears because I realised the severity of it. But it didn't take long for me to twig that this was the best thing to do. And I stuck with it and went through the various processes. That was in the sort of May, June of 2015. And in December, I went into what was then the recommended venue, which was Woodgates at Nottingham. And the procedure there is to have a 1 week, 7 days inpatient detox, where you're given very, very intense doses of Librium. And that has the effect of detoxifying you, i.e. getting the you know, you become not so dependent. I mean, I had the shakes from the moment I walked in, but it's calming you down and getting the substance out of your system. I was actually offered, I was aware that there was a 12-week community rehab program, which is run from Springbank, but for some reason it didn't gel. So I ended up going to Baker Street for 4 weeks, just to sort of carry on. And that was a bit of limited aftercare, although I had information that my key worker was available to me. I actually sort of did the 4 weeks at Baker Street. It was 3 days, 3 mornings a week. But my first port of call on leaving detox was AA. And then after that was an evening meeting. After I finished at Baker Street, I was able to take an opportunity of the wonderful organisation called SMART. Have you heard of SMART? I can only see 3 faces. Ah, right, thank you. You're right. SMART stands for Self-Management and Recovery Training. It was set up in America, and it's come to these shores, I think, about 10 years ago. And basically, you sit down as a group and just go around the room and share your experience. Now, SMART is open to anybody with any addiction. The vast majority of people in SMART meetings are alcohol-related problems. But like I found in detox, I'm meeting my colleagues who have problems with drugs or substance misuse. Just on a quick aside, Smart opens its doors to any addiction. So in our Smart meetings in Beverley, we'd welcome people with a gambling addiction, for instance. Now, Smart offer a whole toolbox, a whole range of procedures, or well, we call them tools, that help you cope with all the sort of elements. And it's a sort of 4-part program. I won't go into detail, but it's well worth looking up. Smart, self-management and recovery training. Now, I, like AA, like Smart, it's a group of people who share their common experiences, and there is a lot of wisdom in those rooms, because you're listening and talking to people who are, you know, coming out with their experiences straight from the hip. There's no messing around, no textbooks, nothing, and it is so important that you're hearing, you know, practical advice and information from fellow sufferers. Now, like many people, coming out of detox, I hit a honeymoon period, and this is now, we're talking about January 2016. So I've been in the detox in the December, thrown myself into AA because that was more readily available, hit Smart in the January, but I also joined Weight Watchers. I went to the gym, lost some weight. I was madly tidying up the house, getting on board with all the things that I'd been putting off for ages. I really threw myself into it. And I also decided I was going to get a part-time job where I'd registered with a temp agency. And looking back, I overdid it because the assignment I was given was a solid 4 weeks. And in those 4 weeks, I then was so committed I couldn't get to AA meetings, I couldn't get to Smart meetings. I'd let my gym membership slip. And at the end of those 4 weeks, I picked up a drink again. And it was a silly thing to do. I bought the girls in the office a little bottle of wine, and I could have given them a box of chocolates, but no. See, I was planning ahead. I learnt this. In the back of my mind, I thought, well, it was a special offer. I needed 7 little bottles. And if you bought 8, you got the special offer. Where did that 8th one go? Not down the sink, not given to my neighbour. And that little bottle of wine suddenly became a bottle of vodka. Don't ask me how. Anyway, that was so disappointing. And I spent, actually looking back on my records, it was 2 months indulging in my vodka again. And I can honestly say it was probably worse than I had previously, you know, the stage I got to when I gave up the year before. I really had, you know, was drowning myself in it. Now, I took the opportunity, having realised there was a bit of a wait to get into a detox back in Nottingham, I took the opportunity of going privately to a detox, and I was recommended a place in Barnsley. So I put part of myself in there, and I literally phoned one day and I was in the next day. And I got all the support I needed, went back to my AA meetings, more importantly my Smart meetings, and by that time I'd made friends with somebody in Smart. I can't say, I must admit, Smart is more preferable because you can sit in a meeting and share and interact. In AA you just sit there, say your piece, shut up, and that's it. So I do relish the Smart meetings because of that immediate feedback. And then, silly me, I went down south to see my family and took the opportunity. I was determined, in my mind, I was telling myself I was going to just have a cider. Of course, cider hasn't got alcohol in it at all, has it? But that cider was actually a bottle of vodka. So I came back from my brother and my family, determined. I thought, well, I'm 240 miles away. You know, when I get home, it'll be I can get back into routine again. Oh no, I wasn't. So there was I, back at the end of July, and through August, drinking again, very, very heavy levels. So I was back in the detox again, thinking, aren't I silly? And my friends in Smart in particular, they saw it coming. They saw that I was planning to go down south, and you know, they actually pleaded that I shouldn't go. So when I got back to my Smart meeting, they all said, well, we're not going to tell you, we told you so, but we told you so. So that really was the last, you know, it took 3 detoxes in 9 months for me to get it into my head that I really, really can't drink. I cannot pick up one drink. Now, at the time, it is very, you know, the thought of it is very daunting. But again, with help of your colleagues in smart meetings and some of the tools that are available from the smart program, I got used to the idea that, you know, you just break it down into small amounts and I can cope. I'm not going to have a drink today. I'm not going to worry about tomorrow. And when you keep it down as simple as that, it works. So I no longer have this fear of, oh, I'm never going to have a drink again. So what? Now, I can't say that I'm not very proud of the fact that I did those 3 detoxes in 9 months, but it's given me such a good grounding and such a good base that I feel that I know where I am and I'm fairly rooted in the spot that I cannot go back down that path again because I know where it's going to lead me. Just moving forward, so having got that experience behind me, the most important thing was I continued with the smart meetings, sometimes twice a week. And by 2018 in the April, I had the opportunity to train as a peer mentor. And I've never looked back. In fact, I know Dave's here. I don't think he can get rid of me. I think it's, oh gosh, what can we do with Alison? She's always around somewhere. The training itself is absolutely excellent. Dave himself takes the course at Springbank, and I found it quite challenging in some respects because it's very intensive, it's very heavy, enjoyable, but it gives quite a lot of opportunity for self-reflection. You really are asking yourself the whole time, you're testing yourself, for want of a better word. Added to which we learn new skills, and in particular the skills of active listening, motivational interviewing, and we get to understand and appreciate the theories of addiction and things like the cycle of change and learning the aspects and importance of recovery capital. So it's a very, it is an intensive course, but very, very rewarding. And I just took the opportunity to look back on what my comments were at the time. When I've noted down, so this is going back to 2018, I felt that it gave me the opportunity to build or rebuild my self-confidence and, more important, my self-esteem. It certainly improved my interpersonal skills, particularly on a face-to-face basis, one-to-one. It gave me very much a sense of purpose, which I thought was very important, because I could actually see a future in supporting the work of East Riding Partnership. And from that extent, I've been kept very busy. Not only do I sit in on the open access meetings, I also sit in sometimes on the aftercare clinics. I've attended the sessions that are held at Springbank, which is the community rehab program. That's the 12-week program. And I'm also a facilitator for smart meetings. I think it helps that I'm driving. I can be fairly mobile, so I do cover quite a bit of the East Riding area, and I've been out as far as Goole and Driffield, Withensea. Basically, I'm based in either Beverley or Brough. And also, I think it gives me an opportunity to give me some stability. I'm at a stage in my life, my husband actually has just retired from the business, so I've retired with him. So whilst I wasn't necessarily looking for a future career, it's just fitted in nicely for me personally at my stage of life. So I've been a peer mentor now for 2 years, and I can genuinely say that I get a real buzz out of helping other people. I'm not trying to be altruistic or anything like that, but you do get a bit of a kick. Sometimes, obviously, things don't work out and people are still going around on their cycle of change and aren't sort of progressing forward, but we understand that. I know my own self. And the most important thing is being able to share your practical experience. And sitting in on some of the clinics, it's not amusing, but people sometimes sort of say, the key worker or the counsellor is sitting next to me and they're paying more attention to me. Well, Alison understands, don't you, Alison? Now, I never sit there and say, hey, been there, done it, got the t-shirt and the baseball cap. But somehow they just sort of can identify that I have been there, done it, got the t-shirt. And it takes a bit of, obviously you learn with experience, but just that click and the fact that you can immediately identify with the way they're thinking. I had a situation which again makes me quite amused. there was a lady I was sort of sharing with her about the fact that we all go to one shop in the morning and another shop in the afternoon, or we don't go to the same shop 2 days running. And she looked at me in amazement and said, did you do that? I said, oh yes, we all do. And she thought she was the only one who thought about that plan of not going to the same shop on consecutive days. And that's before we get on to hiding the bottles in the laundry basket, or men rebuilding their sheds to accommodate all sorts of hiding places. But getting back to the ERP crew, it's a marvellous environment to work and to support. Obviously, I'm a volunteer, but everybody's so genuinely friendly and supportive. And when we've finished a session, I get a genuine thanks. And I will say, look, don't thank me. You know, I'm thanking you for giving me the opportunity. And in no doubt, it's built my self-confidence. I feel that having the opportunity to be a peer mentor, I'm in a very comfort zone. I can't really see me ever, perhaps I can now, further down the line, but I'm comfortable knowing that the people around me understand where I'm coming from, and that I can make myself understood. We're almost speaking the same language, definitely singing from the same hymn book. So the whole experience of the SMART experience going on to peer mentoring has genuinely allowed me to become a human being again. If I can just say, my mantra is very much that alcohol doesn't discriminate. I mean, it can affect anybody, any walk of life at any age. You don't ask to become an alcoholic. It's not self-inflicted, and it's definitely not a weakness. Unfortunately, my time in hospital, and it's no disrespect because I know the medical staff are under a lot of pressure, but I was met with total disgust. You know, oh, why can you be so weak-willed? And that had a lot of impact on me. I really thought it was my fault and that I was useless. And that it was just being, I was being selfish, taking up the resources of the medical profession by ending up in hospital with my withdrawal symptoms. Obviously, I now know a lot better than that. But I do appreciate the nursing staff were under pressure, but it didn't help. I think even now, I've spoken to colleagues about this as well. It's taken quite a lot for me to realise that it is a disease, and there's a lot more to it than that. The key thing too, and I think this all comes back to this May 2015. I realised too that you've got to do it for yourself. You've got to be selfish. You've got to want to do it for you. And whatever happened that afternoon, I mean, it just did. But having said that, you have to do it for yourself, but you can't do it by yourself. And you've got to accept that the vast majority of help that you can get is out there, and it is with other people. And the opportunities afforded, for instance, if we start at the beginning with the open access service, is tremendous because, again, if you're aware, the ERP open access has 7 or 9 locations throughout East Riding, where the service users are quite at liberty to come in without an appointment. They've got friendly face. They usually see somebody who is, well, they always see somebody who's either a counsellor or key worker, titles vary, but the crew are basically social workers. And certainly in the last 2 years, there's the addition of us as peer mentors in these clinics. As I said earlier, this is our opportunity. We're a friendly face, we're informal, and we can offer hope to others that it is possible without saying I've been there, done it, and got the baseball cap. I think the important thing as a peer mentor sitting in on these clinics is the fact that you can say, you recognise you're not alone. Remember the lady who thought she was the only one finding different shops to go to. So you're not alone. And the important thing is you can share in that isolation that most people, all people, suffer when they are using a substance of their choice, be it drink or drugs, that your life is dominated by getting that substance. It's seeking up sources of supply, it's consuming it, it's hiding it from your friends and family. And the fact that in that isolation, you're likely to lose friends and family, you might even lose your job. In severe cases, you could end up on the streets. I have known some people quite surprising when you see them in meetings nowadays to find out that they were on the streets. But also in identifying that people have this sense of isolation and loneliness, you're able to share that practical information, which again I popped on earlier, and that you can physically relate to having blackouts and explain what happens, why you have a blackout. So it's giving practical advice as well. It's so important because we recognise straight away that if you're attending clinics, you're perhaps being asked to not necessarily stop. We very rarely say stop drinking because that can be dangerous, and as you know, that's how you can black out. Your body just seizes up.
Alison, sorry, I'm just conscious that I haven't come to Dave yet, and I know that there'll be some questions and comments for yourself. So if you're okay about taking comments and questions as well, should we just hear a little bit from Dave, and then we'll come back to just if board members have got any comments or questions for you, because I'm sure there will be, because that is such a powerful, honest and moving story with some fantastic reflections there. Dave, is there anything you'd like to just add to the wealth of sharing that Alison's just done?
Well, good morning, everybody. The first thing I'd like to say is that as a trust, we should be really proud of East Riding Partnership, because I believe, I could be classed as biased maybe, but I believe we've probably got one of the best services nationally, because we have such an easy, accessible engagement process for people to access it at the beginning, and then all the way through our system we do practice intensive engagement, but then there's a great aftercare system as well. And part of my role that Alison spoke about is also recruiting our ex-service users to then volunteer within our service to promote recovery to people who enter East Riding Partnership. And I would just like to say as well, Alison mentioned about being in hospital. We also now have a service that is in Hull Royal where there is a liaison service there. So anyone who does come into hospital will be seen by one of our nurses. So yeah, really, I'm just really proud of like East Riding Partnership, and I think we should shout about it a lot more personally.
Thank you, David. And your pride in the service comes through absolutely clearly, and as does with Alison as well in the way she talks about the service. So I know a few people are having a bit of trouble with their hands up, but is there anybody that'd like to ask a question of Alison and Dave or make a comment? Francis?
Hi, Alison. Really fantastic story, and thank you very much for sharing that with us. I was just going to pick up on John's point. Have you noticed any increase in this when you've been working during COVID in the fact that COVID is putting mental pressure on people, and we know there has been drinking going on? Have you noticed any uplift from that at all?
David, I'll pass to you.
What I would say, Francis, is with a lot of volunteers, we have to stand them down at the beginning, which is obvious for obviously what was happening with the pandemic. And we're now increasing a lot of online support for our patients. Our engagement, well, the service has increased, I would say, yes, around alcohol, but as a service, we've certainly not been overwhelmed by people contacting us and needing the advice. What we have done is become very more dynamic and developed other ways of working to be able to engage with people. I know myself, as the service I provide, we've had an increase of adding extra support on top of the practitioner support, and East Riding Partnership, as you know, is a partnership with the Trust, the Alcohol and Drug Service and NACRO, and the Alcohol and Drug Service has set up a live chat that people can access online to ask questions about a family member, their own problem, and then they're directed to the correct telephone number to make contact with us. So there has been an increase, in family support has increased as well. but I would say that we've dealt with it brilliantly, and we're maintaining the support that we need to provide.
Thank you. We've got quite a few questions. Sorry, Francis, did you want to say something follow up to that?
Yeah, I was just going to say that that's really interesting, and that was going to be my second question. Really, was around have you made good use of the virtual, the Zooms and the Skypes and what have you? It sounds like you have been able to make good use of that.
Yeah, most definitely. Another part of my job, I do spin quite a few plates, is delivering these smart meetings in and around the local authority. So obviously we have to shut them down, and they're still currently shut down at the moment through PHE guidance. So yeah, we're now running 5 meetings a week online, but we're doing quite a lot of one-to-ones as well for those people who are a bit nervous of joining a meeting. So we've put aside a Friday to do lots of one-to-ones, and we're looking at now that guidelines are changing a little bit, that maybe we might be able to create a walk-in meeting, maybe, so we could meet in an outdoor park, just for those who are very vulnerable and isolated. So, you know, it wouldn't be a lot of people, but they would have that opportunity to speak to myself, maybe a peer mentor, and share their experience with someone else as well, and we can support them through that.
That sounds a great idea. Right, so I've got Michelle, Dean and Lynn. So Michelle, you first.
It was just to say that Dean needed to come in. I'll pick it up at the end, Sharon, if that's okay.
That's fine. Dean and then Lynn.
First of all, just thank you very much, Alison, for sharing your story with us. I imagine it can't be easy, although you've clearly got some practice of the work that you're doing with us. But thank you for such a clear story and bringing it to us. And I think, as it said in the report that we got, it was Tim Young that was saying about the importance of people talking about this to stimulate debate, and it certainly does that. So it just got me thinking really about a little bit with Francis, really, given that we might anticipate that given the COVID crisis there might be a rise in alcohol use. Is there more that we could be doing as a good employer, recognising that we employ thousands of staff that may be affected by this? Should we be raising in a leadership role things that we could be doing as an employer, as well as setting a good example? May not be an answer for anyone now, but just stimulating that sort of thought about getting in early and letting people know that there are services that are available.
I think as we started, when I started speaking, I was highlighting the fact that it's so widespread, and it can affect anybody. So the more signposting there is to friendly and helpful advice, and trying to get away from that stigmatism. That's why we try not to use the word alcoholic or drug addict. That you've got a substance misuse problem, so I think from what we're saying is every opportunity to make access available with free phone numbers. And I think now as a nation we're getting used to Zoom meetings, so perhaps that's another way that people are getting more user friendly with those. So it'd be quite natural, rather than giving a phone number, giving a Zoom contact. And I appreciate the phone opportunities when if you get on any sites, you often get these chat lines sort of things. So that's the important thing, because people need information, they need reassurance that they're not alone, and they need quality information because they're scared.
Thank you.
Thank you. So we'll come to Lynn, then Michelle for the final comment. So Lynn, please.
Yes, good morning, Alison and Dave. Alison, thank you so much for sharing that story with us. Such an honest account, so thank you so much for that. My point was particularly about the role of experts by experience and the peer support worker role. So the East Riding Partnership, Dave, and I couldn't agree with you more, is absolutely a jewel in our crown, amongst others as well, because the partnership working that you've just started to talk about, and the significant role that people like you and Alison play in the service. This is something that we are pursuing across a lot of our other service areas, particularly across the mental health agenda. So we have just recruited 12 new peer support workers from mental health services, and I'm just wondering, actually, how do we use your experiences to support those workers as they come into post as well? So I don't think that's a connection that's been made as much of as it could be. So if that's something that you would be willing to have a bit of a conversation with me about, I'd really appreciate that.
Yes, anything to help. Yeah.
Thank you.
Thank you, Alison. That'd be fantastic if you don't mind. That'd be really, really good. Michelle, final comment to you.
No, thank you, Alison, for a really, really good, great, and really, I think, good time to have that conversation, because I think we've mentioned about lockdown, COVID. We know that there has always been a bit of a hidden situation in relationship to alcohol usage. And I think it's absolutely right that we, highlight that a lot more than we have, and I think we can start that today. We are trying to link it into our health and wellbeing work. That's picking up on Dean's point from a staff point of view. But I was just thinking about how we could, and maybe not for now, but I think we just need to think about how we can get it out wider in relationship to the story and raising awareness, because we do a lot around raising awareness on anxiety, mental health in general, but I think alcohol is something that we probably don't do as much of, and I think we need to. I would absolutely endorse the thing about David said about the East Riding Partnership. It is absolutely fantastic, and I think we do need to thank staff, the peer mentors and everybody in that partnership, and actually spread the word a little bit more. So I think for me, it's about taking this as a bit of a catalyst to share wider across the region and the system, but actually start to reach out more. It is something. I mean, funny enough, I know you mentioned Barnsley. I was actually part of setting up that Barnsley unit all those years ago. So it was interesting that you mentioned that, because it is such a vital part of the work that we do. So I think probably offline we can maybe just take it a bit more. I mean, whether we do link it into the peer mentor work that Lynn spoke about, but I do think that we need to maybe do a bit more of a communication on this hidden issue around alcohol, not just because of COVID, but because it's been there. So we'll pick that up offline. But fantastic story. Thank you so much for sharing that experience, and thanks, Dave, to yourself and the team as well. But really great way to start the board off. So thank you.
Thank you, Michelle. So just on behalf of the board, can I thank you both for everything that you do all the time. You're both absolutely passionate about what you do, and that comes through and making a real difference to people. So it is appreciated. And as Michelle said, a great way for us to start our board meeting. So we really do appreciate you both coming along today. So thank you very much. And I look forward to hearing what's next in terms of sharing this wider, as Michelle described. So thank you both very much indeed. We really do appreciate it.
Okay, thank you. Have a good day.
Yeah, have a good day.
Thanks again.
Thank you.
All the best.
Thank you. Right, so that was a fantastic start to the board meeting. I can see that Catherine has arrived. Catherine, who is here to present the research and development report, item 16, needs to be away for an important call. So if board members wouldn't mind, and if Francis, you could possibly help with the page number, as you usually do, if we could please take item 16 next, so that Catherine can make her call.
Page 149.
Thank you very much for that, Francis. John, would you like to introduce this?
Good morning, everyone. Catherine is well known to you all. So this is the 6 monthly report update. And we brought some stuff with regard to what's going on in COVID into it. And Catherine is master of all that she surveys. So we'll have all the detail for anyone who's got questions at the end of the report. Over to you, Catherine.
John. Thank you. Welcome back to the board, Catherine. Good to see you as always. Obviously, we've read the report, so over to you.
Okay, I won't go through it in full then, because I'll assume you've read it, but I'll just pick out a few key highlights that I thought you might be interested in. I've done a brief summary, as I did last year, in 2 infographics at the back of the report in the appendices that just show a kind of summary for 2019-20, just an easy read picture format. So that gives us a nice summary of last year. But going on to this year, we are making some progress. We are doing things relating to our research strategy, but we're also very aware that we're in a kind of different environment, and some of those objectives in the strategy might need to be relooked at. So we'll be re-looking at some of those, not changing the strategy, but just rethinking how we might meet some of those objectives. So maybe there'll be more about that in future papers. We have the contract that we have with Yorkshire and Humber Clinical Research Network. We've had this as a partner. We're a partner. There's 22 partners in the Yorkshire and Humber Clinical Research Network. Every trust in Yorkshire and Humber is a partner, and this contract is being extended for a further year, which will take us up to 2023. So we're just asking for the board to approve for Michelle to sign off on that variation to the contract. Without that contract, we wouldn't have the funding that we get in each year to be able to provide all the opportunities for research for our patients and carers and staff. So it's quite an important contract for us to have. Thinking about funding, we've got a fairly steady state in terms of funding, although we're actually in a better position than lots of the other trusts in that we've actually seen an increase from the Clinical Research Network this year based on previous performance, whereas quite a lot of trusts have seen a decrease. So that's a real positive for us. And in terms of COVID-19, obviously our attention has turned to that this year. Professor Chris Whitty, who's the Chief Medical Officer for England, has urged all trusts to prioritise the urgent public health research around COVID. So we suspended lots of our other research and focused on the COVID research. We're now we're restarting some of our other research and taking on some new non-COVID studies, but COVID research will remain the priority. And I'm sure lots of you have seen in the daily press conferences that were from Downing Street, research was mentioned regularly, and we have been taking part in some of those studies that have contributed to the data that's been reported. We have also had some of our research staff trained and volunteered to work. If the Nightingale Hospital had opened, we would have been on the front line as researchers there, recruiting participants into COVID studies. So we are still mindful of some of that work. Fortunately, we weren't needed at the time. We've also taken part in some of the vaccine trials. We've certainly had staff within our trust that have been recruited into vaccine trials. There will be more of those coming, and we will be working closely with Hull University teaching hospitals on those trials. COVID has also brought new opportunities in terms of studies that we couldn't have been a site for before, and we now are, because interventions are being offered remotely. So there is for example, there's a dementia study where it's being run from Bradford, and now that the intervention is being delivered remotely, we can now be a site. So it's actually opening up new doors that aren't specifically COVID studies, but are presenting new opportunities to us. We've also, along with the emphasis on BAME communities, as part of research, we've joined a project team across the region to try and encourage more recruitment into COVID studies for our BAME communities. So we're working closely with our colleagues across Yorkshire and Humber on that agenda. And we're pursuing new opportunities for new COVID studies. We have one that we're hoping to join with TZESC and Wear Valley. It's being led by them, and that's going to be around depression in older people with multimorbidities and the isolation that COVID has brought. That is categorised as an urgent public health study by the Chief Medical Officer, so we're hoping we might be able to join that as a site in the future. And the team have continued doing the promotion that they usually do. So we've done a few radio things and day in the life of a redeployed research assistant. We had some of our staff redeployed into general practice, etc. And for those of you that love the research conference, it was cancelled in May for obvious reasons. It was fully booked, but we're going to attempt to do a virtual research conference on the 17th and 18th of November. So plans are just coming together for that, so keep that date in your diaries, please. I think it should hopefully be in most people's diaries already, so it'd be great if you could come to that. Okay.
Catherine, thank you very much. Enthusiasm shines through as always. We've got a number of hands up, so I'll come to Mike Cook first, please.
Sorry, Sharon, can I just come in first? It's just to reiterate a declaration of interest that's in the accounts anyway, and in the National Declaration of Interest, that I am chair of the CRN, and it'll be signing off potential approval for me to sign something. So before we get into further conversation, I won't take part in that discussion, but obviously I've declared it before anyway. But just to reiterate and remind the board.
That's fine. Thank you very much for that reminder. We'll make sure we minute that as well, Michelle. Thank you. So Mike Cook, please.
Thank you, Sharon. Can you hear me?
We can, Mike, yes.
Yeah. Just to reiterate, one of the reasons why we're getting more infrastructure funding is because of Catherine and the team's success in recruiting above target for both the numbers of people in trials and the width of the trials we're involved with. So well done on adopted trials recruitment, and also being proactive in trying to get involved in the sort of wave of COVID research that is coming up. And in particular, just to underline, I think we were all disappointed the 4th research conference, which is a great moment in the calendar for everybody, was cancelled. But I think it's the 17th and 18th, 2 half days in November. See you there, folks, I think is the cry. But well done again to the team for some really consistent leadership. And I must say, as being research champion for 4 years, I've seen a real incremental growth with Michelle and John's leadership too. I think it's impressive.
Thank you, Mike. Francis and then Peter.
Thanks, Sharon. A couple of things. First of all, I love the infographics again. I think that's great. To show that on 2 pages is fantastic to be able to go and wave around. Like Mike, I'm really looking forward to the conference, and hopefully with it being virtual, you might be able to attract even more people because you're not confined by the room size. So it could actually get bigger than it was, which is great news. Well done on the recruitment. Again, absolutely fantastic results. And I was just wondering, with you talked about the virtual opportunities, has that opened up a lot more now? Because again, people have had to do things differently, and sort of moving people around. You can now do stuff like we're doing here. Does that open up more opportunities for you?
I think surprisingly, it has made us more connected across Yorkshire and Humber. I feel like I see more of Yorkshire and Humber people in other trusts than I ever have done before. I think people can join meetings more and can share ideas more. And certainly, as I mentioned, in terms of some of the interventions, yes, it does close down some interventions, having to work virtually a lot of the time, but it's actually opened up some really good opportunities for us. And some of the interventions that we were delivering face to face, we have actually changed, and they're now being delivered virtually. And that sometimes means that some participants that wouldn't have wanted to get together face to face, or to do group work, or to travel to a clinic, are actually now joining when they maybe wouldn't have done. So I think you lose some and you win some. So there's some positives and there's some negatives, but there definitely are plenty of positives. And I think as a team, we've adapted quite well. We now do a lot of assessments over video and phone calls with people, and people have said they really, really appreciate the contact they've had with us while they've been shielding and in isolation. So yeah, there's definitely positives.
So going forward, once we do get to a point where people can move around, the combination of both face-to-face and virtual should really enhance things.
Yeah, it should.
Thank you very much for that. Peter?
Well, thanks, Sharon. Yeah, thanks for that, Catherine. I think that's a really thorough, varied report, and I'm delighted that we're involved in so many different streams of research across the various areas. So I thought that was fantastic. I'm just thinking about the lead provider collaborative that we're involved in, and the 3 streams there, and perhaps linking it as well with, now that we've got the Inspire unit. I just wonder if we've got the full, or if we can sort of work on that to sort of do more in terms of some of the CAMS research projects that are probably going on around the country. The fact that we've got the lead collaborator position and the Inspire unit. I just wondered if there's anything more we could do there. I mean, there's loads you are doing, does that open a few more doors, the fact that we've got those two?
That's actually really timely, because we've just agreed to do a study in the Inspire Inpatient Unit with Nicola Green as the principal investigator, and that's been run with Manchester and Professor Lavelle, Karina Lavelle. So yeah, that's a really timely question, and we're really pleased that we're just about to start negotiating that. So hopefully, and that's a physical health study. Yeah. So although it's looking at inpatients, young people as inpatients in a CAMHS setting, it's actually around their physical health as well. So watch this space, fingers crossed.
That's great, Catherine, thank you.
That's great to hear. John?
Sharon, I just want to thank Catherine and the team for the response during COVID. As you can see from the report, they managed to keep the wheels on the bus in terms of research, managed to expand into new research areas, but I know Lynn would echo my thoughts that they played a significant role in supporting the EPRO response, and were incredibly supportive of the efforts to keep the operational show on the road. So they were literally double jobbing as we were going along, and I'm grateful to Catherine and the team for that.
Thank you, John. Michelle?
Just to say thanks, Catherine, to the team. I say this all the time, because the work, and I think Mike mentioned it, the success is the recruitment of participants into the research that's growing that reputation, and we constantly exceed our targets, which is fantastic, and I know we'll continue to do that. But more importantly, it's about research making a difference to people's lives, and we don't forget that. We just need to remind people that it is so vitally important, because it does make a fundamental difference. It's great to be part of the COVID work, but it's also great to be part of some of the other work that's going on as well. And one of the things that we continue to do is push the importance of mental health, physical health and learning disability research forward, because sometimes that's a little bit underestimated, the importance, and primary care obviously. So thanks to Catherine and the team for flying that flag with us as well, but let's keep going, more to do, but great work and great progress, so thank you for that.
No, thank you for that. I think Pete Beckwith wants to come in.
Yeah, thank you, Sharon. So, yeah, echo all the points being made. Great paper, fantastic work. Love the infographics. I'm going to go back to type now as an accountant. There is a section 2 in the report asking for approval to sign the variation with the CRN that we do need to document. That's approval for Michelle to sign that CV, Chair.
Yeah, thanks, Pete. I hadn't forgotten that. Good. Any more questions before we move to the recommendation? No, thank you. So excluding Michelle from that item, as she's declared an interest of the board, happy to support the Chief Exec signing the variation to the contract as detailed in the paper.
Yeah.
Yes.
Yeah.
Any dissenting views? No. So that's duly approved. Catherine, really good report as always. I too love the way you present it. I think it really works for me. I think it's fantastic to do that on 2 pages, as Francis said. So well done to you and the team for everything you're doing. Great to see you at the board, and you can see how much the board is engaged in the research agenda. And we will take as an action that everybody will be invited. I think most of us have already got it in our diaries, to be honest, but we will just make sure the whole board gets the opportunity to attend and support your conference. I'm sure most people will want to. So thank you again. Please pass on our thanks to the team, and we look forward to seeing you soon.
Thank you. Can I just say thank you, because this is a super supportive board of research. You are always very complimentary and always back everything we do. So thank you. It's much appreciated. Okay.
Our pleasure.
Thank you. Bye.
Thank you. So if we could move please back to item 6, which is my chair's report. Just like to start with, I know that the board, I did send a note around the board, but I'd just like to congratulate Francis on his reappointment for a further period of 3 years. So Francis' term will now run until the 31st of December 2023. So congratulations to you, Francis. That was approved at the recent Council of Governors meeting. It's been a busy time since the last board. Michelle and I hosted our first virtual quarterly staff awards. These are the awards that we usually host at Trust headquarters or Whitby or Scarborough, wherever we are, for long service, retirees and employees of the month. So we held the first one, and we plan to keep on rolling those out during these periods. And I think it went reasonably well, Michelle, didn't we? It was well received by the staff. So we thought it was important that we continue with those. I was delighted, along with other board members, to attend the virtual NHS birthday service and the service for Pride, hosted by our chaplain Eve. I have to say I commend the team for thinking in a different way and coming up with new ways to engage people and welcome people into them. Both fantastic services, and as I say, my pleasure to attend them. It's been a busy month for the ICS, the Integrated Care System. Lots of sessions with scenario planning and other meetings, and obviously I know I've been reporting to the non-execs, and Michelle and I have been catching up about lots of things going on, and Michelle obviously covers some of that in her report. Also lots of other regional and national events, including Yorkshire and Humber chairs meetings, regulation CQC, race inequality sessions, and Michelle and I have also attended, I think, at least 2 chairs and chief execs national briefings and meetings since the last meeting. So lots going on, lots about the coming up, what's going on, and as I say, Michelle covers some of it in her report. In connection with the governors, we held our first virtual Council of Governors meeting recently, and thanks to those of you who attended. I've had some really positive feedback from governors and others about how that went, and we will be carrying that on for the time being. So the next Council of Governors will also be virtual. The governor groups have all met virtually now and will continue to meet virtually. Particular thanks to the non-execs and to Michelle Hughes, who are involved with those groups. Again, received very positive feedback from those who have attended, and we are working with Katie to try and make sure that we make it as easy as possible for all of the governors to engage in the virtual meetings. I've carried on meeting with the lead governor, public governors, partner governors and other governors, all virtually or through telephone. So as I say, that seems to be going as well as it can do, and hopefully people are feeling very engaged with it. And as I say, we're working with those that are finding it a bit more difficult. So I think that's all from me for this month, unless there are any questions. No? Okay, can we please move on to item 7, which is the Chief Executive Report, Michelle.
Sharon,
Sorry, did Mike Smith have his hand up, Sharon?
Oh, sorry, Mike. Mike, thank you for that spotting. Mike, did you have a question? We can't hear you, Mike.
Might have lost him. Shall we carry on with mine, and then if he joins us back, Sharon, go back?
Press the wrong button there.
Okay, Mike. I thought you dropped offline.
You're now on mute. Oh, you press it. Okay. So do you have a question or not, Mike?
No question. Stupidity. Sorry.
Oh, that's fine. You get that's good. Okay, Michelle. Sorry. So we'll move back to you, please. The item 7, the Chief Executive Report, please.
No problem. Thank you. It just take a while getting used to all the IT platforms, doesn't it? But yeah, obviously, I'll just pick up the virtual awards because you mentioned it, Chair. Just to say that we did hold them. They were really successful. And we'll continue to. They're the long service, employee of the month, etc. And we'll continue to do those. It is a bit difficult, but I think it's important that we do continue to acknowledge their long service. We've caught up with all the backlog that we had, and I think it's really important that we acknowledge that, and I think staff appreciate it. As usual, I'll take it that people have read my report. I'll pick out some headlines. I'm continuing to do quite a lot of work with the MPs. I've mentioned the Emma Hardy forum that we did, and I thank Kwame and Lynn for joining me on that. It was really well supported by constituents, but I think it's important that we work really closely with the MPs. We do anyway, but especially at this particular time, and I had a very positive conversation with Diane Johnson yesterday as well. So we will continue to do that, and I'll continue to feedback. There's no immediate concerns. They're very happy with the way that we're communicating and the way that we're handling the pandemic, but it's important that we continue to link in with them and their constituencies. Great news about the commendation for Amy Gledhill, the higher trainee. I don't want to pick something up later, but it was absolutely fantastic that we continue to get these awards for our trainees, and that we continue to support our trainees as an organisation. And again, that's really good for the individuals, but also for the medical education team as well. I continue to dial into all the teams across the trust, and I'll continue to do that. It's actually really good because I think we picked up earlier that, I think Catherine mentioned it, that actually more people join the meetings than if you sometimes go on visits, because it's easier just to dial in. I suffice to say that morale is still high, but there are patches of fatigue, that irritability patch that we thought would happen as part of the COVID process. And I know that Lynn will touch on this in the report, but we are doing a lot to support staff. We're making sure that people take leave, monitoring that leave, and we did a health and wellbeing week, which again is in my report, which went down really well, and we're working very closely with the Shiny Minds app. In fact, we're actually working with the developers on that, so watch this space, because we're probably going to launch something with them nationally, because we are one of the trusts that's using that app the most, which I think is really positive. So again, that's really good, but we will continue to support staff's health and wellbeing, and continue to drive the support processes, because there is lots of different stages that staff are going to go through as part of the pandemic. It was great, however, to celebrate the 72nd anniversary of the NHS. It seems 2 minutes since it was the 70th. And I'm not going to say I was there at the start of the NHS, but sometimes it feels like I might have been. But it was a really great session with lots of different things. It started off with a great service, all the way through to lighting up Inspire Blue to support the charities, etc. And I know that staff did individual things as well. So that was good. I don't want to go into too much about winter, but we are heading into winter, so I am going to mention it. We have signed off our flu plan, and I thank the team for that. We want to be ahead of the curve with this. I've already raised the issue about making sure that we get the vaccine as soon as we can. We're looking to see if we can train up about another 40 peer vaccinators. If you remember, we did really quite well on the uptake last year, but we want to continue to improve on that this year. And I think we just need to do as much planning as we possibly can across all the scenarios for the winter that we're going to be leading into, with COVID, with flu, with various other winter diseases, etc. So we will bring a winter plan to the board in September at our September meeting. Moving on from that, people will know it's not in the report, but it is Pride Week this week. We're doing a lot to celebrate Pride, so please have a look. Lots of virtual things happening. There was a great service again to start us off last Friday, and there's lots of different events that people can dial in and out of, so please have a look at that. Moving on to the integrated care system. A lot's happening with that at the moment. We are starting to really look at how we utilise the integrated care system. And I've mentioned some bullet points that we're looking at, which is around potentially looking at merging budgets of some respect, having more accountability within the ICS, the keeping organisational sovereignty, but having more accountability through the integrated care system. The governance, I think, is beginning to move forward. We just need to make sure there's not too much duplication with the two developing subsystems. And we've got a couple of leads. Population health, it's Andrew. Bernell and Amanda is leading on the flu campaign alongside primary care. The most important thing, I think, the headlines this month is the capital plan. That work's been done. As you know, there's been quite a lot of money being put into mental health capital, but that's for dormitory provision. So we're looking at the next tranche of that. We haven't got a phase 3 planning guidance yet from the centre. That is apparently due out this week, but it was due out last week. We think we'll get some more guidance this week on the people plan and money. But up until then, we're working through what that means in relationship to the two subsystems. And we've done some phase 3 plans at the moment that haven't been signed off yet, but they're nearly there. But they're quite weighty documents. Once we get the truncated versions, which are more the exec summaries, we will share those, and we'll certainly put them on the board in September. And hopefully they will relate into the phase 3 national plans and the planning guidance when it comes out. But the highlights are in there. The Humber subsystem is developing well. We're looking to get an MOU in relationship to that. And the North Yorkshire structures have been in place for quite a while, so we're just developing through those at the moment. And Brent has started now as Chief Executive of Tees Esconway Valley, and I'm linking in very closely with Brent. As I say, I've known Brent for a number of years, so we're working very closely on that. And I think I'll stop there, Chair. There's lots of things in there, just giving some highlights. I would just add 2 things about the comms, because there's quite an in-depth comms section and Health Star section, and I thank everybody for their work on that. But comms, please have a look at the new website. I am going to embarrass Adam again. He has done all that more or less himself, and that is no mean feat. If we'd have sent that out to a commercial company, it would have been a significant finance. So I think it's fantastic. I'm a little bit biased, but I think it's really fantastic. I've been playing around with that all week, and it is just so interactive and what have you. So please let me have your comments on that. And we have done 2 posters which we'll send out to the board. One which is around meetings, and how and why we should be getting into meetings, and we'll pick up the next phase of COVID in the report, but also about IT platforms, about having a break, and I'm sure we'll have a break soon, Chair, from this meeting, just for a couple of minutes, just to get some downtime. So we've set out some key principles of that, but we'll circulate those to board. So if I could ask Michelle to maybe do that as an action, that'd be good. But I'll stop there.
Okay, we've got quite a few hands up. Thank you very much for that, Michelle. And can I echo your comments about the website? I have responded, actually. That was sent around all the non-execs, I know that. So yeah, fantastic piece of work. Well done, Adam, and your colleagues, really good. So I'll start with Mike Cook and then I'll work round, please.
Thank you, Sharon. Thanks, Michelle, for another strong report and bringing it to life. I've got 3 comments and questions, if I give them all, if I may. The first is on 1.6, and it's to reinforce the importance of the health and well-being link for staff. 4 months in, keeping an eye on that, getting a temperature check all the time, and linking it to the winter plan, as you said, but also then thinking about our people plan and how that integrates. So perhaps I'll just put that there as a comment. And I would like a specific, please, on 4.1, which is the mental health campus re-provision. I would like to understand, not necessarily now, but what the patient and public involvement actually is in the big set piece meetings, or the other way of doing it. I'd like to hear some reassurance that there is genuine patient public involvement. I can see the stakeholder involvement. And finally, on 4.42, that's a comment from Helen on, that really please see track recruitment coming in as a system. What intended benefits are we likely to see? So those 3 things, if I may. Thank you.
I think I'll pick up some and then I'll pass them over to my colleagues for others. Obviously, health and wellbeing is so important, Mike, which is why we'll continue to do the exec, and I'm dialing into all the meetings, and we've got a real long planning relationship to continue to support staff. And I think this next phase has to be around leave and having some headroom. The other thing that we're doing is trying to stand down as much as we can for August. So have a bit of a rest and recoup in August. So anything that's not essential, non-urgent, then we're suggesting that is stood down. And I know the team are on with that at the moment, and that includes obviously some of the corporate things as well. And if you remember what we did instigate, which went down very well, which was the meeting free Friday afternoon, which allowed the clinical staff to plan for the weekend in relationship to the contingency, the beds, etc. Also to take stock of the week and the week come in, but also the corporate teams as well, just to again have some headroom. We're going to reinstate those, because with IT platforms it's really easy to start to fill your diary, as we all know, and I think that's why it's so important we've done the key principles for best practice on IT platforms, which will go out. We've just signed that off, and again thanks to Adam and the team, making it really simple, very picture focused, because I really like pictures, as you know. Keep it simple, because I think that's really important. So I think it's constant. And again, we look to the workforce committee, we look to people around the table for any advice and support, or any things that they've worked before or that they've seen elsewhere, because we cannot do enough to support our staff. They are so important, and it is such a long period for people, and it's going to continue. And there's all the emotional things with personal and all the other stuff that we're finding on day-to-day basis. So we will continue to keep going, and we'll continue to do as much as we can to support everybody. Sorry, can I pick up the campus? Lynn P, do you want to pick that? We are going to put the campus on the board timeout to have a bit more of a discussion about, but I don't know if Lynn wants to pick up the engagement piece. And then Helen, do you want to pick up a little bit about the outcomes that we're inspecting in track?
Yeah. Yes, thank you, Michelle. In terms of service user engagement, Mike, obviously that is key to this programme of work. So to date, we've already had engagement in developing the clinical model, and Mandy Dawley's team are working closely with this programme of work. We did have some service user engagements through the 3 option appraisal workshops that we've just undertaken. I have to say not everybody that we invited attended those, but I think that's understandable in the position. Going forward as well, I think you've already mentioned it, we are going to instigate a stakeholder reference group as well to have that wider participation across the communities. We've already got some of that and had that to date, but we know that we want to strengthen that. Given where we are within this programme of work, I think it's the right time to do that now, and with Mandy to make sure that we've got the breadth of service user engagement as we get closer to completing our outline business case. So it's certainly very much, you know, our intent, and we are committed to that. We have had some, but we can do a bit more.
Okay, thank you, Lynn. Helen, would you like to come in about the outcome of track?
Yes, thank you, Chair. So the main benefits for track are for streamlining for managers in the main, and also to support candidates accessing our vacancies across the organisation. So at the moment, our recruitment services are very paper heavy with lots of spreadsheets and lots of email exchanges. This will support managers to enable them to very quickly advertise vacancies as they wish, and there's no longer going to be to and fro in between individuals to approve documentation and so on. The other benefit that we've got with track, which is really exciting actually, is our ability to link it to our new recruitment platform that we will be launching shortly, working closely with comms, and it will enable us to directly identify those vacancies, and when individuals who are interested in working for us link on it, takes them straight to the applications process. At the moment it's NHS jobs and it's a little bit clunky, I have to say, so that removes all of that. And then the final benefit is our ability to be able to very quickly run management reports and understand what's happening with our KPIs.
Thank you, Helen, really helpful. Thanks. That's okay, Mike? Answered your questions? Okay, I've got quite a list. Michelle Hughes, don't worry, I haven't forgotten about ratifying the policies as well. So I'll take you in turn. So Francis first, please.
Thanks, Michelle. Mine's a couple of comments with the odd question. So under 1.2, just fantastic news. That's really good. So thank you, Michelle, for pointing that one out. My second one, we're probably going to pick up later. I was going to ask some questions around, as Mike said, 1.6, but 1.7 and 3.2, the whole winter bit. But if you're bringing a full winter plan, we'll probably wait till then. I'm assuming that'll come in September, will it? Because there isn't a board in August yet.
Yeah, that's what Michelle said. She said September, so it'll come to the September board.
Not for answering now, but again, I liked the stuff in Hillary's section around CPD funding and the extra monies. And once we started spending it, it would be good just to have some stories and some examples of how it's being spent, and maybe publish those so that people can see the benefits of what comes out of that. I think would be really useful. And then my other one was on hard copy pay slips. For an experience somewhere else, I'll just be careful, just a note of caution that some members of staff struggle to do stuff online. And we had a whole set of one team somewhere else I was at who it became a real problem for them not being able to get hold of a hard copy of their pay slips, and we ended up reverting to hard copy just for that group. And it was domestics in this particular case who really struggled to access stuff and couldn't get to their pay slips, so we ended up putting them back in. And then the final one was just a well done on the Unbelievable recruitment campaign. I really like that strapline. It looks really good. And there's some, later on, you can see how the advertising and vacancies are going well, and this sounds really good. So well done on it. That's it.
Thanks, Francis. I think there is a comment in about some staff groups and the pay slips in the report as well, I think, which is helpful. John, I'll come to you next, then Michelle Hughes, then Hilary.
So Chair, I just want a word of thanks to board members who've come along and supported the virtual work that Mandy's team have been doing over the past months. You'll all be aware we've had a virtual Veterans Festival a couple of weeks ago, which went well. We're having a virtual Pride Festival this week, which is also going well, but also the virtual services on Sunday, which have really taken off, and I think culminated in the NHS birthday one. So I just want to thank those of you who've had the opportunity to come and join us. It's much appreciated, and it's a great fill up for the team. The other thing I'd just like to particularly sort of thank is Adam and our comms colleagues, because they've generated an awful lot of material during COVID, and they've produced some great infographics and graphics which are all around our ward, just demonstrating to staff and to patients what's the right way and what's the wrong way to do stuff. And it's just much more effective than producing lots and lots of policies. And we've produced a great one around meeting etiquette as well, Sharon. So I don't know if Adam's in a position to share it, but I think the comms team have produced some really wonderful stuff, which is I take real pride in. So I just wanted to put that out there too.
Thank you, John. That's really helpful, and I'm sure, as Michelle said, we've already taken it as an action that we'll send the posters around the board so we can all see them, because I don't think they've been, as we haven't all received them yet, so that'd be good. Thank you. Michelle Hughes.
Thank you, Chair. I was going to follow up on Michelle's comments, but I noticed that Helen, Francis and John have referred to it slightly as well. So just briefly, the COVID work, the COVID intranet pages have been further developed, and in addition to the daily staff comms, 21,000 views by staff, proving to be an invaluable resource to them. So that's fantastic work. The Unbelievable, we've already mentioned, is part of the recruitment task and finish group. And again, Adam has done fantastic work on that website that will link to ours. 20 staff groups involved, interviews taken place, and the campaign will be closely aligned to our brand work that you've all been involved in too. And just one other thing to highlight is Popolo, which is an internal comm system that other NHS trusts use, and it will allow us to target particular staff groups, which will be fantastic, because one of the gripes of many NHS staff across all organisations is they're inundated with emails and therefore don't read them. This will really allow us to provide a focus and target emails to relevant groups. Thank you.
Thank you, Michelle, really helpful. Hilary.
Yes, thank you. I did want to just draw the board's attention to section 4.2 around the continuous professional development monies. I mean, it's fantastic getting that amount of money into the trust for CPD. Couldn't have come at a worse time in many ways of trying to spend it, given that we've lost 2 months due to the pandemic of being able to access training, obviously get staff to start to bring in what they want for their CPD. So we are putting the action plan together. Staff are obviously now going through their appraisal processes, and we're reminding everybody to make sure they raise about CPD in their appraisal and get that identified. So that is coming in. Some of the issues we've got, the challenges we've got, is around some of the providers of some of the education. Obviously, they're not doing the face-to-face now for obvious reasons. So we're waiting really for them to get it online, etc. So working through that as well. So it is quite challenging, but we are getting our action plan pulled together. I was going to propose that I took something to the Workforce Development Committee, if the board agree with that as being a place to take the outcome from our action plan, what sort of things people have put forward, and a bit of an oversight of that, and also whether or not we have been positively looked at in terms of our action plan, that we're going to get our second tranche of money as well. Because I think once people get into this, know the money's there, they will want to use it more, and they'll get into it. And we have allocated £1,000 for everybody, so we're looking at putting some admin behind that so we can actually manage it and see that people are accessing their CPD. So it certainly is a positive for the trust, and certainly people are coming forward with their requirements.
Thank you, Hilary. Is everybody happy with that suggestion of the action plan going to the Workforce Committee? Yes. Okay. Anything else on that paper before we ratify the policies? So I think we've agreed that the winter plan will come to the September board meeting. We will circulate the posters around the board. Just to confirm that we will be having a session on the mental health campus at the September board development day. I think it's the 2nd of September. And the action plan for CPD will go to the Workforce Committee. So we are asked to ratify the policies mentioned in the report. Are we happy to do so? Any Any dissenting views? No, we're happy to do that. Can I just suggest we just take the publications report and then we have a short break and then do the other half of the agenda, if that's okay. So Michelle, item 8, the publications report.
Thanks, Chair. Again, I'm not going to go through this in a lot of detail. People have had sight of the report. If there's any questions, then please, I'll answer them as much we can or pass them to the relevant person. Okay, any questions on the report? No, you're all keen to get a break. That's fine. Can I suggest that we just break for, is 5 minutes long enough just for everybody to stretch their legs, get a drink? So we will start again just after 11 o'clock. Adam, could you just stop live streaming and then restart again?
item 9, the performance report. We'll restart the public board meeting, please. So Pete, to you, please.
Thank you, Chair. So, usual report. This is a report at month 3, so the end of June 2020. You'll notice from the graphs that we've started to shade those graphs for the start of the COVID pandemic, so we can see how that has or hasn't affected our performance. We've included in the commentary on the front sheet for those indicators that fall out of the statistical process range. And I think if I take the report as read, and we just move straight to questions, Chair.
Okay, thank you, Pete. Any questions on the performance report? Peter Barron, we'll start with you. Thanks.
Oh, thanks, Chair. Yeah, it's just a quick question on the dashboard again, because you know, if you take this and you take Hillary's paper later, I just wonder where the board were getting assurance from on safer staffing on the Inspire unit, because it doesn't appear any in either here, because it's not been RAG rated, and I don't think the Inspire unit is yet featuring on the safer staffing report that Hillary's done later. So it's just really where are we getting the assurance from?
Thank you, Peter. Hillary, would you like to reply?
Yeah. So obviously assurance around Inspire is the dashboard that we've got in front of us. The next 6-month report, obviously Inspire will feature in there, because it'll be that full 6 months with Inspire being open and the beds being available. Just on Inspire, I was actually going to raise my hand just to say about the no return around the clinical supervision. That was an oversight, unfortunately, from the team requesting the information for this dashboard. They didn't ask Inspire for the information. The clinical lead has confirmed that they have got full compliance with clinical supervision. So obviously going forward, that now they are being asked for it, it will start to appear there. In terms of there being no RAG rating on the fill rates, that's because the fill rates are based on both Orion and Nova being open. So that's why if we've got them, they'll all look red, because we haven't actually got all those beds open yet. So they've just taken it off for the time being. And we assume the board are okay with that, otherwise they'll all look red, which actually isn't the case. I think the thing with Inspire is to look at the care hours per patient day, which you will see is very high, which is a good indicator. So it is this. Obviously, we've got regular meetings with Inspire. There's lots of behind the scenes monitoring and working with Inspire going on, certainly from Lynn and myself and others as well. With it being a new unit, new team, so there is a lot of close monitoring going on there. But that's why the figures look a little bit different, I think, this time, because all those reds were quite unfair, really, and gave the wrong impression, we felt, because the beds aren't open yet.
Okay, Peter, did you have anything else? Are you happy with that?
That's fine. Yeah, thank you.
Thank you. Mike Smith, we come to you next, please.
Yeah, thanks, Sharon. Page 59 of the pack, it's the sequin 72-hour follow-ups. I know Mike Cook commended this last time. I'd like to commend this again. That is a really, really impressive looking graph, that. And it was evidence-based. If colleagues remember, this came out of some of the work from the confidential inquiry about the 3-day period. I'd just like to ask, are we an outlier in that, or is anyone else doing the same? A positive outlier, that is.
Michelle,
do you know from the network?
Yeah, no, there's not a lot of people. There was a lot of talk a few years ago, because it did come out of Lewis and Nav's work several years ago in relationship to the 7-day follow-up. And then they actually did some more and actually said, well, yes, 7 days actually does reduce suicides, but actually 3 days is the most important fit. And we actually did think a while ago, a couple of years ago, that would actually bring it into the mandated targets, but they never have at the moment. I think there are a few organisations that do it, but not as strictly as us, because I feel it's one of the key targets that people know that I feel very strongly about. I mean, I feel strongly about all of them, but this is really linked to evidence, and you really can make a difference in relationship to self-harm and suicide. So I think we are a positive outlier. Is the answer to that, Mike. They're not that no other trusts are doing it, but I don't think they do it as strict and as regimentally monitored as we do.
Thanks, Michelle, and perhaps Teacher McGrath, it's okay, because you might want to raise this in your mental health network as to what's been done, because it really should be replicated across elsewhere. May I just ask one more question, please, Sharon?
Yes, of course.
That's about cash in bank, and we see an enormous increase on the graph on 74. I think it's explained by 75. I think we're in a spend and claim environment now, and we're in front with the block funding is the way that I read it. But the reason why I raise it is that this is a public meeting and public papers, and I think we need to be very clear that this rise in our balances is due to specific circumstances, not that we're squirreling away cash.
Yeah, you're absolutely right, Mike. It's the fact that the national response to COVID put an extra month's block into all providers nationally. So in theory, we have our July block payment in our June account. What we don't know, and I mentioned this before on the board, is when that cash will be recovered, because there will be some process of clawback. You would expect it to be this financial year potentially, because obviously the cash limit for the NHS will be set. So at some point we will see that cash go back to its normal underlying position.
Thanks, Peter. It's good to minute that. Thank you. Thanks, Jenny.
Thanks, Mike. Next to Francis, then to Dean.
Thanks, Chair. A couple of comments and a couple of questions. So on page 47, just to complement the sickness absence data for June at 4%, which is dropping, which is great, although I'll pick that up again a bit later. Moving then on to page 52, just to say well done to the team on training. To have held up the level of training despite everything else we're going through should be complimented and well done to the team. Like Mike, I wanted to mention the page 59, which was great. But on page 54, it was just interesting that total number of incidents reported on Datix seems to have shown a steady increase during the COVID period. And I just wonder if these were linked to COVID or not. So if I can just park that question, I'll put everything on the table and then come back. So it was just that. On our old favourite, page 56, the dashboard, going back to the fact that sickness was good at 4%, it was then interesting to see the levels of sickness on here, which were all massively above 4%. So I was just trying to work out the link between that. You can see if you walk down there, there's a lot of different sickness levels, all well above the 4% level. So that was a quick question. And then my other one was that it would be remiss, not to talk about RTT, which continues to drop. And whilst I know it's covered on the front sheet, also about waiting times, which continue to rise. And I know there's some explanation on there, but just to pick that out. So those are the kinds of areas I was interested in.
Thanks, Francis. If we just take them in turn. So, Hilary, could you just respond to Francis's question on the incidents, please?
Yes, absolutely. The rise in incidents, although still obviously within the controls, would be due to some incidents on Spire. We had quite a bit of self-harm incidents on Inspire in that particular month. I think it's dropped off again since then. Some of those young people have moved on. But again, that for me represents a really good incident reporting culture in Inspire. They really do report everything. The incidents were all low or no harm, so that's positive as well.
Thank you, Hilary. Helen, would you mind responding on the sickness figures?
Yeah, so the sickness figures that we've got there, which are really, really fantastic to see in terms of our current position. In response to the question, the information that was provided, I believe, is for the unit. So this is across the whole organisation, and our sickness rates demonstrated with that across the whole organisation. I think that answers your question, Francis.
Okay, thanks for that. I'll pick it maybe further at workforce at the next meeting, but yeah, okay, that's fine.
Thank you.
Thank you. And then, yes, the situation with waiting lists and RTT and complete pathways. Lynn, would you mind responding to that?
Yes, of course, Sharon. So as I've discussed here before, the areas where we're seeing those increasing weights are really those areas that have been directly impacted by COVID. So I guess it's not a surprise that this position is here. Obviously, operationally, there are significant plans in place to address this. So the key areas remain the ones that I've talked about previously. They are paediatric, autism, spectrum diagnostic service, the adult autism service. There is an increase in weight as well for some of the physical health services that we've just not been able to provide in the same way. So, for example, physiotherapy in Scarborough and Rydale, paediatric therapies that we're just very limited in how we've been able to operate that using the remote technologies. Given the title, they are physical therapies, and speech and language therapy, which obviously does not lend itself well in terms of providing that using the digital medium. Obviously, we have refreshed all of these pathways where we are able to now. We are obviously standing up some of that face-to-face contact to improve the lists. We've got improvement plans in place across all of those areas. I'm working very closely with BI at the moment as well. Obviously, I think I would be assured, and I think you would be assured, if we can demonstrate the improvement trajectories that we're expecting given the operational interventions that we've made. Because we have changed the pathways quite significantly to accommodate improving the waiting times, BI are working on those. They certainly will be ready for September. So if that's agreeable, I'll share them with the board then. But obviously this is a huge priority, working very closely with our commissioners around those areas as well. But they were the ones that we expected. They have been directly impacted by COVID.
Francis, does that answer your question?
Yes, Sharon, thanks very much.
Okay, thank you. So we'll hear more on that in September, as you suggested, Lynn. Thank you very much for the response. So next is Dean, and then it's Michelle and Pete. So Dean,
Thanks.
please.
Thanks, Sharon. It's just a general point, first of all, just again, when you look through the performance report, just how well things have held up, where we might not have anticipated that right at the start of the COVID period. So, great work all round in terms of the way that people have adapt to the working arrangements and that to keep on delivering as many of those services as we can so well and effectively. There's just a general point just about the sort of staff sickness, absence and turnover, which I know that Francis had touched on, and just acknowledging the positive trend there, but also saying it's a time when we don't really know what's going on in the workforce in other organisations as well. So just to be keeping it under review. So it may be that we've got some sickness absence, for example, that people working at home aren't reporting it in the same sort of way because they're not going into work, don't need to report it. There may be some that's sort of displaced into the COVID absence. Likewise, turnover when there's been less sort of movement around organisations in terms of job availability. But really good stuff, and something we can, I think, drill down a bit further in the workforce committee to make sure that we're understanding it, and then constantly benchmarking about what's happening in other organisations as well to make sure that we're adopting that sort of best practice where we can find it.
Yeah, thank you, Dean. Michelle?
Yeah, thanks, Chair. Just to pick up a couple of points. I think one, following on from Dean, actually, about the sickness. I mean, I think Francis asked a question about the particular hotspots that we've got, because we have still got some hotspots. If you look at the safer staffing dashboard, that certainly has been discussed at the executive team, but I think it would be really helpful for me now to ask the workforce committee to really look at those hotspot areas and just to see what because I know there's a lot of work, and I know the executive management team do cover this, but I think from a subcommittee point of view, I think it's timely, and notably things, obviously we're talking about like Ullswater, etc. I'm not going to list them now. We know the hotspot areas, so I'll ask Lynn if she could maybe work with Steve McGowan just to maybe do a little report into the workforce committee on some of the hotspot areas and some of the targeted work that we're doing, because they're still hotspots. So if we could do that. And the second thing is about waiting lists. I know there's a lot. Again, I know there's a lot of work going. We do monitor it at the executive management team, and I know that ODG do as well. But again, if you remember a while ago, and I can't remember exactly how long ago, so apologies, the quality committee did a bit of an overview of how we ensure that that we're keeping up to date with some of the patients on the waiting list, especially those that are waiting for a long time. It might be timely. And apologies, and I'm going to ask you if you don't mind doing this through the team, just to relook at that and just to assure ourselves or reassure ourselves that we are maintaining some sort of contact with them. I think it's probably timely just to have a look at that, especially in this next stage of COVID, because we can say, oh, it's due to COVID, and I think that's right, but I think we don't need to be complacent about that. We need to make sure that we're still keeping abreast of, and I know we are, but how we're monitoring the patients on their waiting list. So there's two pieces of work for the subcommittees for me, Chair.
Thank you, Michelle, for those suggestions. Is everybody happy with those suggestions? Yes?
Yeah.
We'll take them forward. Pete, did you, sorry, your hand gone down. Did you have a question?
Sorry, I was just going to come in on the points that Dean and Michelle have both raised in terms of sickness. We know we have the hotspots, but we also know that performance in our non-inpatient settings has improved. And I guess what we don't know is how much of that is, I don't want to use the word benefit, the impact, but more the impact of home working and people who would traditionally maybe not have come into work, but because they're at home, they feel that they're not off sick because they're actually still being productive to a degree. But I'm sure the report that Michelle's asked for through the Workforce Committee will flush all of that out, Chair.
On mute, Sharon.
Sorry, Michelle, did you have another point you wanted to make? You're on mute, sorry.
It was just at the end, Sharon, just if I could have the final comment, that would be really good, if everybody's finished.
Yeah.
Thank you. I think everybody's asked my questions or made my comments. So is there anything else on that? Jenny will take those 2 suggestions from Michelle as actions from this.
Sorry, Chair, can I just say then, can I just thank the team, because it's very, I know that we do thank staff, but can I just thank the executive team particularly, because it is a good performance report on all fronts. Yes, I know we've got a couple of hotspot areas, but when you look at the benchmark in particular, we have maintained a really steady ship and improved some areas. So can I personally thank the executive on behalf of the board and the teams that work with them as well.
Yeah, I'm sure the board would echo that and include you in our thanks as well. So thank you to you all. So can we move on then, please, to item 10, the finance report, please, Pete?
Yeah, so thank you, Chair. So again, this is the finance report at the end of Q1, month 3. I think it's important to remind the board that we're still operating under the COVID governance arrangements, so we're not in business as usual. I think these arrangements are going to continue at least until the end of September. We haven't had that confirmed yet, but it's highly likely. And then we're still, as Michelle mentioned earlier, waiting guidance on what's going to happen for the latter part of the year. I guess the key highlights from the report I'll pull out before we go to questions are: we recorded a break-even position at the end of month 3. That's what we're being asked to do. But within that break-even position, we did have 2.7 million of COVID claimed costs, which was broken down roughly 1.9 million of additional expenditure and 800,000 related to top-up income. I can confirm to the board as a point of assurance that our COVID claims for month 1 and month 2 have been reimbursed, and month 3 has been written off, supported by the regional team. So we should have that reimbursement next month. As requested at Finance Committee, and as I mentioned at the board last month, we have now apportioned where we can the COVID claims to try and show the true financial position across divisions and corporate areas. There are still a few limitations to that in terms of particularly the true-up income, but we have got a more true-up financial position within the body of the report. We mentioned cash in bank earlier. It is bolstered by the additional block payment, but our underlying position is still 15 million, which is strong for the trust. I mean, I will stop there, Chair, and I'd be happy to take any questions.
Thanks, Pete. Questions on the finance report? Peter Barron.
Oh, thanks, Chair. Thanks, Pete, for that. It's quite a clear report. Obviously, we've got a Finance and Investment Committee coming up in a couple of weeks. So I'll leave more detailed questions perhaps for then. But just on 2.3.4, you talk about secure services and the cost of enhanced packages of care. And I just wondered if, in the current environment, what's the scope to sort of knock on the door of the CCGs or whoever's funding the enhanced packages of care to or it might be NHSI and NHSE, but to try to recover some of that money that's being spent on those packages.
I mean, traditionally, Peter, we would have invoiced for those enhanced packages of care to NHS England. However, the current architecture is such that we can't actually do that because their hands are tied and our hands are tied, and we're operating on this block arrangement, so a predetermined calculation. So we are recovering probably that expenditure through the true up as we true up to break even, because obviously we've claimed 800,000 year to date. However, the difficulty is that true up covers quite a lot of areas where we would have recovered income, so we can't apportion that to the specialist care group. Hence why it then appears as an overspend in the year to date position. So at the moment, the scope to recover it direct is limited, but the assurance I can give is we are recovering it and flagging it through the true-up process we've got with the regional team.
Okay, thanks, Pete.
Okay, thank you. Any other questions on the finance report? Peter's asked one I was going to ask. My other one, and apologies for this, Pete, I probably should know this, but can you just explain the finance technical items to me again, please?
Yeah, so let me just have a quick look in finance technical. So within finance technical, Chair, there'll be a combination of the BRS provision we provided for, which is to account for any non-delivery of BRS between now and the end of the year, and COVID income through true-up that we can't apportion across divisions.
Right, okay. Thank you. Anything else on that? No, thank you. If we could then move on to item 11, which is the Quality Committee Assurance Report and February minutes. Mike Cook.
Good morning again. Thank you, Sharon. This confirms in summary form what I reported back to the last board from the 18th of June meeting. It does underline the fact that we were all assured about the COVID response and the use of the quality systems that we have. We meet again actually on the 5th of August, and we'll put into the work programme the relook at longer waits, I'm sure, through that. We're also going to contribute to the on quality, but I don't know if Hilary and John want to add anything else.
No, I say that it's the report, as you say, Mike, that we reported last time, and we've got a very full agenda next week, so we're on it.
Thanks, Mike. I think I'd just like to comment on the huge amount of lifting which has gone on, particularly in ops, to keep the show on the road, and actually double job in terms of doing external strategic as well. And we've had a look at a performance report, which I think shows some good progress and some great work under unprecedented circumstances, irrespective of one or two sort of factors dropping off. And we've discussed the Quality Committee, we've discussed here at board the huge lifting that Lynn and her team have done. And I think it's really important from my perspective that reiterate it. The NHS over the next 1 to 2 to 3 years is going to have to do a huge period of rebuilding, particularly in acute services. We are going to have to be patient and do some rebuilding in some of our own services, particularly around the CAMs and some of the therapies. But we need to understand that we're starting from a pretty good position, irrespective of some of the challenges we've got in 1 or 2 areas. And we do understand the impact that will have on families, patients, carers, particularly children. But we mustn't forget that the staff have kept the show on the road, unlike in some other places. And I just want to put that on record, please, Mike.
Thank you, John. Anything else on the assurance report or minutes? No, thank you very much, Mike. If we can move on then to item 12, which is the Workforce and OD Committee Assurance Report and May minutes. Dean?
Yeah, thanks very much, Sharon. And just if I could thank Jess Norton in Steve's team just for helping me turn this around so quickly. We have the Workforce Committee on the 15th of July, so we'd like to get this to the next available board. You can see the sort of highlights there from the insurance report. I suppose the things I would just draw attention to really are we talked about the sort of impact on recruitment and turnover, and you can see some of the real changes there in terms of the number of staff that have been recruited through that. We welcomed the appointment of Grace as the chair of the BAME network, and are going to invite her to the committee to see how we can support her and that work. And looking through the sort of insights report, we got a fair bit of assurance about the work that's going on there. We also are keeping on track the sort of hard to recruit posts, and the task and finish group work on that, and we'll just keep that regularly sort of under review. But happy to take any questions on that.
Thanks, Dean. Helen, did Steve want to add anything, do you know, in particular?
No, not really, Chair. Just to say that we're really starting to work closely now with the operational areas. We brought the first staff survey information through, which worked really, really well. So we're getting a bit more of an insight into what's happening in each of the areas.
Thank you. Peter, you've got a question?
Yeah, I was going to perhaps ask it earlier, but I'll ask it now. In terms of the retirement policy, I noticed that we changed the retirement policy to make it easier for for people who have retired to sort of make a contribution sooner after they've retired to return in some capacity. And I just wondered, because we did have a recruitment campaign earlier in the year, and I think Steve at the time did say that there were 8 people who had come back to work for Humber who had previously retired. I just wondered, given that we've changed the policy and given that it's a bit of time since we asked the question, have we had any more people? Have we had many more people, say, coming back after retirement to help out? Because we are approaching a period of time when people are getting a bit tired, you know, and it may well be that people go on the bank and perhaps can fill some of the shifts and help out to relieve some of our permanent staff, if you like. At a period when I think they may well need rest and relaxation.
Okay, Helen, would you like to answer that?
Thank you. Yes, so we have had some successes with the retirement return, particularly the Bring Back scheme that was launched earlier in the year across NHS organisations. So there's been some successes there. We did also write to all of our recently retired employees to ask them if they were interested in retirement returning, particularly those of our staff that were clinical, and we did have some successes there as well. We do continue to re-engage our staff following retirement, and one of the reasons that we reviewed the policy is to make it easier for staff to retire and to return, to set out clearly the arrangements and to enable that to happen within a 24-hour period should they wish to do so.
Thank you, Helen. John?
Thank you, Chair. Dean, you've been here a little while now. I'm just wondering, with going back to the Workforce Committee, we looked at quite a lot of data over the last couple of meetings. Do you have any thoughts about how we're doing when it comes specifically to benchmarking, please, across some of the key metrics and how we compare to other people in the system?
Yeah, I think we're doing positively in terms of benchmarking, John. So I know it's something that Steve regularly keeps under review, and it is the point I was alluding to earlier in terms of things like sickness, absence, and turnover. So while we can see some improvements in those areas, and that's good in absolute terms, it's also important that we check out what's happening in other organisations to see if we're on the same sort of trend with that. So I think having reliable and regular benchmarking data that we can have a look at is really important. The other point I generally make is that benchmarking tells you what's common. It doesn't tell you necessarily what's right. And so I think it's right that occasionally that we see some benchmarking data and say that we can do better than that, or that might be the common position, but it's not what we aspire to. We want to do things that are right about it. So I think having a good understanding about what benchmarking is telling us is happening, not necessarily what would demonstrate, for example, best practice. So the point that Helen was making earlier, I think, about the work of directorates in doing with things like the staff survey and the impact that they can have on the ground in that distributed leadership model that we're trying to get, I think is sort of really important in terms of trying to push some of that. And then we start to become the leader in some of the sort of benchmarking areas. But I know it's something that Steve is keen to have a look at, and we see regular benchmarking information from other organisations. Sickness absence is just one good example of that.
Thank you, Dean and John. Michelle?
Yeah, thanks. I was going to just reiterate the point that Dean made. Actually, we do a lot of benchmarking data, and it goes into the insight report for the Workforce Committee. But again, we do treat it with some sensitivity because of the reasons that Dean mentioned. But we actually do quite well across the board in relationship to benchmarking, and we do that wherever we can and in all of our insight reports. But we'll continue to do that. And as I say, in the main, really good, really positive. But we do need to be careful that we continue to strive for excellence.
Thank you. Anything else on that? No, some good discussion. I've just got a small point on the minutes. Francis is a member of the committee, not an attendee, so that just needs to be amended for future minutes. So if we could just record that Francis is actually a full member, not an attendee, that'd be good. Thank you. We can move on to item 13, which is the Charitable Funds Committee Assurance Report and January minutes. Mike Cook.
Thank you, Sharon. Yeah, Charitable Funds Committee, you've got the report of the 21st of July meeting. Again, thanks to the team for turning that round so we could see it today. And you've got the minutes of the 21st of January meeting, which was some time ago, but we did actually see the papers for the one that was planned just before the COVID outbreak. I would say the committee and its functions have been active since then. At the committee, we looked at the COVID period. There's a case study which I'll finish on, if I may, before handing over to Pete and Peter for comments. We looked at the risk register. We looked at the Whitby redevelopment. Great that we've got a 13 million plus scheme funded. How do we enhance that through the Charitable Funds Committee? We think we work best with the Smile Foundation when we've got an appeal running, and that's an obvious one. So there'll be some proposals back on that, and I know Michelle is active with Andy and others in discussing that. So that was a good discussion. We've also looked at some indicators and how we look at performance going forward to build on the conversation we had as a board with the Smile team in February. And there'll be some look at performance ratios and things like that, which we think are quite material, and I know have been an interest. So I'd just like to finally commend the work. There have been 5,184 hampers, not only distributed but sourced. You know, finding things initially to put in them was obviously quite a battle, and working with the volunteers that we have, I think that's been a great thing. So I did just sort of suggest you see the story of that, and there's a little précis of that for you. We also agreed to support the book of COVID, and Michelle asked us to endorse that, which we were very happy to do, and also the wobble rooms as well, where, you know, when people have had a tough shift and they just need to just have a bit of time out, again, that was highlighted as something that's really added value and was very responsively done. So I just wanted to highlight those things. But Pete Beckwith and Peter Barron, you may want to add a couple of comments. But that's the Charitable Funds Committee update.
Thank you, Mike. Pete Beckwith.
Yeah, I mean, just to echo what Mike said, I thought it was a really positive meeting and some good progress being made in that area. I think the request from the committee to bring the finance and the sector wishes report together worked really well. We got more of a comprehensive picture of fund zone and fund zone balances, and we did actually task Andy to have a look at the fund zone balances and how we can maybe look to maximise those for staff engagement, which we know is a priority of the board. There's a couple of papers elsewhere on the agenda on operating plan KPIs, which Mike's talked about an annual review, so we'll pick those up a little bit later. But yeah, all in all, I thought, you know, some good progress.
Thank you. Peter, do you want to add anything?
Yeah, no, I think Mike summarised it really well, and Pete's added those comments. So it was a really good meeting. I was impressed at how quickly and effectively they spent the NHS Together money that came in. I mean, all too often we have money comes in and it just sits in a bank account, but on this occasion we've really responded fantastically well to get those hampers delivered to all those people, so that money was really well spent. And I'm really looking forward to doing something positive on Whitby. I think that's the next key task that Mike alluded to there, and I think that should be very exciting.
Thank you. Mike Smith.
Yes, echoing what Pete said about getting the money out the door, absolutely excellent and compares very well with other trusts that I know of. I know we're on the 29th of July, but if you spend all the money, you're eligible to bid for up to £50,000 worth of extra funding. So that could be the Whitby one. But I'm just wondering if Smile are on with that. If not, they've got 2 days to get a bid in.
They are on with it, Mike. So they've been having
brilliant, fantastic. I thought they would be. Thank you.
Thank you for that. Okay, well, thank you. Can I say I really did enjoy seeing the case study. It was really good to share that, because we're all trustees of this charity, and I think it's really nice to feel, for those of us who don't regularly attend the Charitable Funds Committee, it was really good to see the case study, and particularly in these challenging times. So thank you for sending that. I found it really useful, and it was good to see. So thank you. If we could move on to item 14, which is the COVID update response, Lynn. Thank you for doing this paper. They are really useful at this time. Obviously, it's quite comprehensive and we've read it. So over to you, Lynn.
Yeah, okay, thank you, Chair. I'll just obviously pick out a few key points. Appreciate people have read it. So obviously this is our report covering the last month and the issues that have really been sort of dominant through that period of time. So the report actually says we've obviously maintained our emergency planning arrangements over the last month too. So our command arrangements, bronze, silver and gold, continue to meet. We continue to have an incident control room that's operational. And I guess the key points from the report, the operational pressures overall have remained manageable across the divisions during the last month. However, as expected, we are now seeing some of those demands in particular areas start to rise. Particularly currently, that's probably evidence in some of our mental health areas. It's starting to be a bit more evident across our physical services in Scarborough and Rydale too. I'll come back to that. We talk about the sort of system planning arrangements and the work that's been taking place over the last month. So overall, our bed occupancy has remained good. So slight rise compared to last month, sort of 65 to 75% usually. And we've already touched on it through some of the conversations that we've already had around the importance of making sure that our staff presence at work and the sickness absence related issues are monitored very closely. I feel that we are doing that. We still have a daily sit rep arrangement in place that reports the position across all areas so that we can respond as necessary to that. We did see a very slight rise in the month in relation to COVID related absence. That was specifically connected to a test, track and trace incident that occurred in the Inspire unit. Obviously we've moved on from that now, and overall, as we've already discussed, our sickness absence is an improving position. Obviously we do have some hot spots which we've already touched on in some of our inpatient areas, but we are doing a lot of work around that currently. In terms of testing, our testing arrangements have remained in place. They are robust. So our PCR testing for our patients and staff continues. We've had no issues in relation to that. We have now completed virtually our first phase programme of the antibody testing. So we set that out to you last month, and so that will conclude on the 31st in terms of the whole scale programme that we've just run. We are waiting for further central guidance around the future of that programme. So as and when we get that, obviously we will respond to that. So the uptake figures are in the report for you. So I'm happy to take any questions in relation to that. We probably will still have some proviso to do some ad hoc testing if necessary, perhaps, for example, staff that have been shielded and perhaps not had the opportunity to access it, but that large scale programme will cease on the 31st. We have got a facility to respond to any positive COVID testing relating to our staff and that ability to track and trace their contacts. So we did have a little bit of activity early on in that, but actually the need for that has been quite low during the last month, obviously, which is good. With no particular PPE issues over the last month. That's running pretty well and smoothly at the moment. We have completed all of the estates risk assessments, so the COVID safe working assessments. They are all done now. So that has led us obviously to do some works across some of the areas, and we continue to look at that. For some of our buildings, that has created some pressures. We're working through those, but obviously that has been, and will continue to be a challenge. Obviously, that means that we're not going to be able to have all of our staff return to the buildings. That won't be possible with the restrictions. So that home working, remote working, agile working, it's really key and important that we continue to maintain that where we're able to. Other services are really adapting to that. So we are looking, for example, at where it's appropriate to have staff at work in buildings that we may well have to use sort of rota type arrangements. So we're looking at that on a sort of service by service basis at the minute in terms of what will work best. We've already touched on the staff health and wellbeing element of the work that we've been doing. We've been really focused right on from the outset on this. I'd really like to connect the work that we've been doing around that to the improving sickness absence position, but we need to maintain that. Michelle's already mentioned that our staff are at work, but they are reporting that they are fatigued and tired. Obviously, the message that we've been reiterating and are monitoring across the operational areas and corporate areas is that need for our staff to take their annual leave and to take breaks. So we've got measures in place, certainly across operational services, to manage that well, and we are monitoring that very closely. I think we've already touched on it. Our offer does seem to compare well to other trusts. The Shiny Minds element has been received very positively by staff. We've already touched on the Health Stars work and the hampers as well. So that demonstration of our appreciation for how much we value our staff is really well and positively received. So I know we've got plans to continue to do that as well as we go forward from here. Staff risk assessments has been really key for us over the last few weeks. So we'd already been on the front foot with this work, offering our risk assessment to all of those staff in the vulnerable groups, but also to all of our staff who wanted, even if they're not in a vulnerable group, to take that up. So we are now obliged to report to the NHS our progress with completion of those assessments. So we are doing that. We've focused across all the vulnerable groups first. So our BAME group has been really key to us in that. And I'm pleased to report, in terms of our substantive staff, we can demonstrate that we've got 100% completion of those risk assessments. A couple of outstanding stuff are actually related to our bank, but we'll complete those by the end of the week. Got plans in place around that. So that's been a really big focus for that. I did also put some of the information from the national work around BAME, and I know we've got Steve's paper as well that sort of sets out some of the work that we've been doing, but really through the command arrangements and the clinical advisory group, focusing on how we make sure that we support our BAME staff given the risk around COVID, and also our service users and patients too. So that's been a real focus for us over the last month. From the system point of view, already touched on it. We are obviously working on and have submitted our phase 3 plans, both from an activity operational perspective and from a finance perspective. So those are going through various approaches around sort of scenario testing, stress testing, and obviously with the winter factor as well that we've already touched on being really key. So those plans are obviously coming about now in terms of how we make sure that we've captured that. Specific work has been undertaken across all of our patches, led by our public health directors and leads around local outbreak plans. So again, we've participated in the development of those. Again, there's been various system events to stress test those, and I'm sure those will continue too. So again, it has actually been, although we haven't had COVID positive inpatients for a little while now, which is great news, the impact of COVID obviously is still very much evident in the work that we are doing. And, given the national position with, local outbreaks and so forth, that's very much been at the forefront of our planning. So I'll stop there, Chair. I know there's other information in the paper, but I think those are the sort of key issues for last month.
Thank you, Lynn. Very comprehensive. Michelle?
Yes, thank you. Just to continue that just a little bit, just picking up on the regional and the national work. I mean, obviously, we've been very heavily involved, as Lynn says, in the outbreak plans, and we are part of the outbreak groups now, the very small focus groups. So we've got a place on those, which is positive. Nationally, they main, because obviously I'm in a couple of the national groups, the main thing, obviously, element is that the NHS still remains at level 4 and will continue to do that for a while, is around the local outbreak planning process, because as you're aware, they're going into a more localized lockdown position or local restriction point of view. In relationship to our area, we've been quite fortunate in relationship to the number of positive cases, and we'll continue to do that. There's been a couple of little hotspots over the last week in the whole area, but nothing significant at the moment. But obviously we are keeping a very close eye on that. So we will continue to do that through the outbreak meetings and through the public health arenas. Nationally, the two things that they're really focusing upon are obviously trying to model it as much as we can from a mental health point of view, but also the inequalities. we've mentioned around the effects of COVID on those from particular inequalities type backgrounds, not just the BAME population. So they're doing some work nationally on that, and where the key to influencing that and supporting that work. And I think that's really important going forward. In relationship to the organisation next steps, two things. I mean, obviously, it's really important to continue to support staff, which we've mentioned, and we will be offering another little token. We've done various things like packs of little afternoon tea parties. We're going to be giving people little badges just to say thank you, and lanyards as well. So they will be coming out very shortly. But the issue around staff risk assessment, it's fantastic news that we've got to 100% from the BAME, but we need to continue to push the assessments. And I know that John has been asked to write out to those particularly at risk to make sure that they complete them. But for me, it's about completing all of our staff to make sure they've got those risk assessments and keeping them up to date so their situation change. And Lynn's touched on the shielding aspect as well, because obviously we've got some anxieties around staff coming back from being shielded over the last 4 months. The next steps, we have got around about 45% reduction in our estate capacity with the risk assessment. So what we're doing is we've always 2 principles to work through: health and wellbeing of our staff and patient safety and quality of care, which have been our key focus all the way through this pandemic and will continue to do so. So we will be looking at some sort of hybrid model, and we'll be putting out some podcasts and some communications later on this week, beginning of next week. And that's about bookable offices and the estates team. They've done some great work on, as Lynn said, assessing capacity and assessing those risks. But we have to work with staff who are in very difficult situations, who want to come back in to support their colleagues, but who can't because we've just not got the physical space. So it'll be some sort of hybrid arrangement whereby there might be a rota. If there's 4 due in, they can only get 2, so there'll be 2 in, 2 off. So we're leaving a lot of that to local discretion, but we are going to set out principles, and that goes the same for HQ. If people come into HQ, it's completely different now. Everything's marked out. The rooms have got a number of desks available, and they've got bookable rooms. So if any of the board, certainly the non-execs, want to use any of the rooms, then they are bookable through the various, and we'll send out the details of how to do that. But I think just to say that still lots to do. We need to take August, as I said, to just have a little bit of reflection while continuing to work within the COVID world. But we do need to plan absolutely everything for the winter, because it's going to be a tough winter, and support staff through that process as well. And I think Peter's point around returnees and retirees is really important. We need to continue that recruitment. We need to continue to bring as many staff back into our organisation, or to get the staff from other organisations, sorry about that, as we can, to support our current staff as well as our patients. But I'll stop there, Chair, because there's lots of work going on as you will. And again, I thank the team as well.
Thank you, Michelle. John?
Sharon, I know people don't particularly like personal praise, but I just want to compliment Lynn on the bewildering number of plates she's had to keep spinning over the past 3 to 4 months. I think we've all worked hard at exec, but Lynn in particular, and I think the report that she's brought highlights some of that work. So as a colleague and a friend, I'd just like to pass my thanks over to her.
Thank you, John. I'm sure Lynn will be thrilled with that. Thank you for making that.
Thanks, John. And the operational managers, actually, I think they are a bit of the unsung heroes in some of this work, but they really have, I have to say, and I've said it before as well, I think the corporate effort, the way that we have worked together across all areas, we wouldn't be in this place without that. So thank you.
Okay, thank you very much. Really useful discussions and fantastic to get the update. As I say, always greatly valued. Can we move on to item 15, the safer staffing report, Hilary? Obviously, comprehensive report. We have read it, and I know it's been to quality. But over to you, Hilary.
Yes, thank you. Yes, it's been to executive management team, and we agreed workforce and the OD committee, so it's been there as well, where it was well received. This obviously shows the picture up to March, just as we're going into COVID. Overall, it's a positive report, and certainly that was fed back from the committee and executive management team. The majority of units are maintaining adequate and safe fill rates. Certainly in terms of any incidents we get, and obviously looking at the incidents on a daily basis as well, we always look at any safer staffing related incidents, and there haven't been any at all that have caused any harm whatsoever. There tend to be incidents that reported to say that they were short staffed, but then obviously, as we would expect, management have helped them to rectify that position. So that's a good position as well. I think the element that really I think we need to focus on is section 5, which is that care hours per patient day again. And notwithstanding Dean's comment earlier about benchmarking, the fact that we are benchmarking well both with our peers and on a national level, and we've sustained that position all the time that we've been doing this report. I think what we need it's the last column in there that we've just added now, which is where some trusts are starting to add in the allied health professionals that are obviously ward based, and that's what we've really got to get behind now, because in our figures, although we're still top of the shop there on that end column, we've not included our AHPs yet, so that's the work. We've got to get them onto the rosters and start pulling them through as well, where they're based on the units, so that we're giving a true picture there of those people that are actually providing care to our patients in the inpatient unit. So we've got meetings this week with some service managers and the matrons, both Lynn and I, to make sure that that work does actually start to progress, and we have a true picture then of those professionals that are providing that care. So, I mean, I think that's all I really wanted to say about the report. I mean, obviously, sickness levels we know are still an issue, but we were in a good position as we went into COVID. And I think because we tried to clear as many beds as we could, ready to obviously thinking that we would be taking COVID patients, which we did. I would like to think the next 6 months that will follow this report will be a positive position as well, and obviously it only pulls on the monthly reports that we bring to the board anyway, so there shouldn't be any surprises in this report. I think for me it's that benchmarking piece that's in here that gives me that assurance that we are adequately staffed on the units.
Thank you, Hilary. Any questions on the report? I know it's been through, as Hilary described, EMT and a subcommittee. Anything? No? Thank you very much, Hilary. Really good to see. And as you say, some real positive work progressing as well. So we'll look forward to the next one in 6 months' time. So we've already dealt with item 16, the research and development report. So move on to item 17, which is the BAME workforce report. So Helen, great to see this. Over to you.
Thank you, Chair. So this report is to provide an update on support and actions for our BAME employees, our BAME colleagues. So what I thought I would do is just pick out some key highlights in the report for you. So in particular, we have established an equality and diversity inclusion working group that's actually meeting later on this week. So that's really positive news. We've facilitated a very well received setting equality priorities for 2021, working with staff, patients and carers earlier on in the year. That worked really, really well. We had young people as well as our patients and carers and staff. We have been working closely with our partnership for the Stepping Up programme. Unfortunately, it's been paused this year at the moment, but we're waiting to hear further news on that programme to support our BAME colleagues in development. And as already mentioned, we've put risk assessments in place for all our BAME colleagues at 100%, which is great news. Since the writing of the report, the figures have increased on there. We're really pleased to announce that we've now got a chair for our BAME group, and we've got a first meeting set up for the beginning of September, so that's really, really positive. In relation to the information provided from the RES data, we've directly responded to that and starting to look to develop some response to that. So, for example, the zero tolerance campaign event we're looking at doing, so we're just currently pulling all of that together at the moment. We are looking to roll out some awareness training for managers on bullying and harassment particularly, and reviewing the policy as well to support that. We have paused that until September because of COVID, but we are looking forward to rolling that training out as well. And as well as the BAME networks, we are also pushing other networks as well. So our LGBT and our multi-faith groups as well. We are looking to push those forward, as mentioned earlier in Dean's report. So I'll stop there and I'll just wait for questions. Thank you.
Thank you, Helen. Dean, do you want to add anything? This has been to Workforce Committee, I think, hasn't it?
No, there was a report, I think, at Workforce Committee that Steve was going to be bringing this to the report, although we did discuss some of the aspects of that. No, I think it's obviously been a very topical issue, I think, over the last few months, you know, as a result of, I think, the impact of COVID, but also the publicity that things like Black Lives Matter's got. And absolutely right that we focus on some of these areas. My only suggestion was going to be, just in terms of proposed actions, is whether it might be timely as well, Helen, just to be having a look at the statutory mandatory training we do around this issue. I think, you know, in light of some of the structural racism that we start to see in society, is whether we start to sort of reflect some of that sort of training and development in terms of the modules that we do. I know we've got that as part of the sort of ESR program, so it might need some liaison there, but I think worth looking at. But I think a really helpful updated report.
Thank you.
Thank you for the suggestion, Dean. Mike Smith.
Thanks, Helen. Great report. Thanks ever so much for bringing it into the round and saying it doesn't sit in isolation. There's also LGBT and other groups that we need to consider. One thing that did set me off on this report, though, is this is about our workforce. I'm very conscious that at Mental Health Ledge, we mirror that and we look at detained patients in terms of Black and minority ethnic. I'm just wondering how we look at our patient group as a whole in community, not only in mental health, but bring it into the round as to how we deal with our patient group. Perhaps not one for this meeting, but it's just something that struck me as a thought.
Okay, thank you.
Okay, thanks, Mike. Anything else on the paper? No, as I say, really useful paper, Helen. Good to see. And I know various of us have had discussions with both Michelle and Steve on this issue. And you're right, and attended lots of national meetings and others, and ICS work as well. So lots of work ongoing. Really good to see. So thank you very much for the report. Item 18, the Trust Constitution. Michelle Hughes.
Thank you, Chair. So the Constitution was last reviewed a couple of years ago, so we had another look at it and for effectiveness and see if any changes were needed. The key changes that were identified were to Annex 1, which provides greater clarification of the description of the public constituencies. The second change was regarding the appointed governors, so that where an appointed organisation considered that an individual continued to be the most appropriate people, capacity is now there for that to happen, subject to Chair and Chief Exec being satisfied that that remains appropriate. The changes were approved at the Council of Governors on the 16th of July, subject to a minor change to a reference to the chair, to chairman instead of chair, and they are now presented to board for approval, and subject to approval they will become effective immediately.
Thank you, Michelle. Any questions on this paper? No. Are we happy to approve the changes to the Constitution? Yes. Any dissenting voices? No. Well, that'll be approved then. Thank you very much, Michelle. And you'll also note that Michelle does flag up the next round of elections. The process is due to start in October, and that will take effect for the new governors from the 1st of February next year. But it's a big year for elections. We've got, I think there's about 10 seats, isn't there, yeah, Michelle, or something like that up for election. So it's approximately 2/3 of our public constituencies are up for election. So some are eligible to restand, but it is a big year for elections this year. So we'll keep you updated as that progresses. Item 19, risk appetite. Michelle, did you want to say something about this paper?
Yes, thanks, Chair. Good to see it, and I think it was on the work plan, but I think we normally do spend a bit more time on this and have more of a detailed conversation in relationship to the appetite levels. So what I was going to suggest, Chair, is that we take it into the board timeout and have a bit more of a conversation, because we usually do it in a board timeout, and then obviously we can agree what levels that we want, because especially I think with COVID as well, we could do with that bit more time to just digest it and have some conversations with it. So I would suggest that we deferred it for then.
Thank you. And I know that's my view as well, but Hilary, are you okay with that?
Yes, absolutely. Yeah.
Everybody okay with that? We'll take it into a more discussion environment rather than trying to do it in the public board meeting. We normally do that, so that's fine. Thank you very much. And we'll invite Oliver along when we do that. So if we can move to item 20, which is the Health Stars annual review. Pete?
Yeah, thank you, Chair. I mean, if I take the paper as read, we covered a little bit of this in the Charitable Funds Assurance Report, because the version of this paper did go there. I think the main concern, if that's the right language to use, when we discussed it at the Charitable Funds Committee was, the changes in workforce at the beginning of this year. But, I think we then took a little bit of assurance that does seem to have stabilised now. And I'll stop there. I'm happy just to go straight into questions.
Okay, Mike Cook, is there anything you would like to add before I take questions? Mike? Okay, well, move to questions. Has anybody got any questions on the paper? No, I think you're right, Pete. I think it's that's stabilised, but I think they've had a good year and certainly supported greatly with the Inspire fundraising, and then particularly during COVID. So very positive report and good to see. So thank you very much. Thank you for that, Michelle.
Yeah, no, just to say, obviously we had a long conversation at the Charitable Funds Committee on it, really, considering the the environment that we're working in at the moment, even more tougher than it normally is. I think Health Stars have been really superb in that, and a lot of the work we couldn't have done. We've mentioned a lot about supporting health and wellbeing of staff, that we could have done it without them, without our volunteers and without Health Stars. So just to note, it's good work in a very difficult situation.
No, great. And please pass our thanks on to the team, Pete, because I know they've worked really hard, as you say, in quite challenging situations, and it has made a difference. If we could move then to item 21, the Health Stars operating plan KPIs, Pete.
So again, Chair, this is a paper that went to Charitable Funds last week, and Mike covered a little bit in his assurance report. So if you recall, Health Stars came to the board back in February and talked about the operating plan and what the board would like to see. They've then developed that into a bit of I'll call it an assurance framework with some key performance indicators. For me, obviously, reverting to type, I think it provides us a framework against which we can kind of monitor and assess the performance of Health Stars and the performance of the charity, which allows the Charitable Funds Committee to then provide that level of assurance back up to the board. I think we recognise the committee, sorry, Chair, we recognise the committee that some of the indicators might need nudging a little and refining, but we thought it did provide us with a good framework on which to move forward.
Thanks, Pete. Mike, I don't know whether you're with us. Mike Cook, do you want to say anything?
Yes, I'll come in now. Both of these items Andy presented to give us a baseline to hold them to account, which I think was a good positive move. Peter Barron brings a sort of continuity. I'm bringing a bit of new challenge in, and I think they welcome that. So my personal view is we get the best out of this relationship when we've got an appeal as well as the background activity. And looking ahead, the board seem to like those principles and those 8 sort of areas they've been told, along with Pete, to work up some indicators so we can keep track of it strategically. Thank you.
Thank you. Any questions or comments on the paper? Mike Smith, did you want to add something? I thought you were waving at me. You obviously weren't. No, that's fine. Anything from anybody else? Can I just say it's good to see this, and I think it's nice to carry on that link that we had with the board with the session in February to this as well. And I think it's that nice connectivity which we did talk about in February between the board as trustees and the charities. So thank you for bringing the paper. It's good to see, and as I say, I think it's really good. Just you know, not every month at all, but just regularly like this between February and now to have that link with the board, because we did say that was something we needed to improve when we had our session in February. So thank you for these two papers, good to see. Okay, if we can move on please to item 22, which is the Council of Governors minutes. I'll just take any questions if there are any. Any questions on the Council of Governors? No, thank you. If we can move on then to items for escalation. I don't think there are any. Has anybody got any? No. Any other business from anybody? No. Well, in that case, we will close part one of the board meeting, the part where we meet in public, and we'll just have a short break and then we'll move into part two. So Adam, thank you very much for your support with part one, as always, really appreciated. And thank you to anybody who has joined us by the live streaming or followed the tweets. Really appreciated the shown interest in the trust. So thank you for joining us. Board members, how long a break would you like